Good morning, delegates and all the participants. Thank you for joining Shield Connect. Today, we are back with our series, virtual learning series on pre-eclampsia VLS-PE 2022-23, session 4, sponsored by the Society for Maternal Fetal Medicine, India. Without wasting much time, let me introduce the moderator of the session, Dr. Anu Joseph. Currently, she is the consultant and medical director of Trinity Healthcare Clinic, Electronic City, and also obstetrician and gynecologist, fetal medicine consultant at Kaveri Hospital, Electronic City, Bangalore, and also visiting consultant of fetal medicine. I welcome you, ma'am. Thank you for joining, and I will hand over the session to you.
Thank you, Sahiti. Welcome to one and all to our fourth virtual learning series. I would take this opportunity to now welcome all our panelists, our chairpersons and moderators. First on the list, Dr. Prakash Mehta. Sir needs no introduction. Sir is our co-chair for the PenI project and also the president for the Society of Maternal Fetal Medicine. Sir is the chief and head of Department of OB-GYN. Welcome to you, sir. Next, I would like to introduce Dr. Sarosh Rana. Madam, welcome. And Madam is the chief, section chief for maternal fetal medicine and professor of OBG in the University of Chicago. Madam has been our international advisor for the SFMI and is a co-chair for Global Health Committee as the ISHP. Welcome to you, ma'am. Beyond today's initial presentations, we would have a panel. Dr. Revati would be the moderator for the panel. Dr. Revati is the Chief Consultant, Maternal Fetal Medicine and Managing Director of Mirror Health Clinic in Bangalore. She's also the Visiting Consultant MFM at Milan and the present Secretary of the Society of Maternal Fetal Medicine India. Dr. Revati is a co-chair of PenI project and is the organizing secretary for the ISHP World Congress 2023, which is to be held in Bangalore in September 2023. Welcome to you, Dr. Revati.
Thank you so much.
In the panel, we have our esteemed, before the panel, Dr. Sushma would be giving us a small talk on HELLP syndrome. She is a consultant maternal fetal medicine at Dr. Jyoti's Healthcare Private Limited at Mysuru. She is an elect member or executive committee member of the Society of Maternal Fetal Medicine India and is a co-author for the study, the Robust study. Special interest is in high-risk obstetrics. Welcome, Dr. Sushma.
Thank you.
On our panel, we have our esteemed members. Dr. Lalitambika, Madam is a former professor and HOD Department of OBG from Government Medical College, Alappuzha, and presently Madam is working as the Senior Consultant in Gregorius Medical Mission Hospital, Parmula. Madam is a past president of KFO and the present president of Alappuzha OBG Society. Welcome to you, ma'am. Next in the panel, we have Dr. Hema Priya. Dr. Hema Priya is an active member of SFMI from the Mysore chapter. She is an associate professor at GSS Medical College Hospital, Mysore. Special interest with endoscopy and high-risk pregnancy. Welcome to you, ma'am. Dr. Harini is our executive committee member at SFMI. Doctor is working as a consultant of OBG at OM Hospitals, Bangalore. Special interest being in fetal and reproductive medicine, high-risk pregnancies, IVF pregnancies, and recurrent pregnancy loss. Welcome to you, Dr. Harini. Dr. Rajni Uday. Madam is a professor in HOD Department of OBG, Saptagiri Medical College, Bangalore. Madam is an excellent clinician, academician, surgeon, and a teacher, and her fields of interest are high-risk pregnancy, fetal medicine, and micro-invasive surgeries. Welcome to you, ma'am. Beyond the panel, we would have a discussion about the conduct of PenI, the work of PenI, and how the pre-eclampsia education of the nation India has been going on for so long and how it works. Dr. Deepti will be giving us an insight into it. Dr. Deepti is a medical director and fertility consultant at Ma Fertility Center, Yelahanka, Bangalore. Doctor is executive committee member of the Society of Maternal Fetal Medicine India, and her special interests are infertilities and pregnancy after infertility treatment. Welcome to you, Dr. Deepti. With this small introduction, now I would invite Dr. Prakash Mehta sir and Dr. Sarosh Rana ma'am for their presidential addresses and to start the meeting beyond.
Namaste, everybody. It's nice to have you on this pleasant Sunday morning for our fourth session, a virtual learning session on pre-eclampsia. We have taken pre-eclampsia from the Society for Maternal Fetal Medicine in a big way, and we have been doing all possible, maneuvers to see that the care to the pre-eclamptic women in India improves. I'm very happy to say that most of our programs have been received very well, and even our current program is right now being streamed live on YouTube, where we have many hundreds of delegates watching this program. I also take this opportunity to welcome you to the HELLP World Congress 2023. For those who are a little uninitiated, let me tell you that the International Society for Study of Hypertension in Pregnancy is the world body that makes all the guidelines for the management of pre-eclampsia. And this is the first time that it is coming to the South Asia. And we are lucky that we are going to host it in Bengaluru. So I would request all of you to be present for the conference, and also to not just be present, because we have promised HELLP that we are going to have an academic session in a very big way, and I would request all of you to make sure that you present papers in this Congress, and presenting, if your paper gets accepted, then presenting a paper in a World Congress is something which will really work wonders on your CV. So especially I request all the youngsters to be sure that they come on and present some papers for the HELLP 2023. With this, thank you, and hope you all have a wonderful learning, because we have got the expert panelists from various cities across. I think today we are mainly concentrating on South India. So we have from Bangalore, Mysore, Kerala, and so on. So happy learning to everyone. Thank you very much.
Dr. Sarosh Rana, I would now request you to give your presidential address.
No, thank you very much. And I would echo what Dr. Mehta was saying in terms of, I agree. I think the PenI course is also taking off in a very good way. So again, people who don't know about it, perhaps they can reach out to Dr. Revati or Dr. Mehta and try to do those modules. I think we did spend a lot of time on it, and seems like it's actually quite successful. Same thing applies to SMFMI. I think, it was a long time ago, not that long ago, 2017, I think, when we kind of, thought about it. And now it's so nice to see that there are so many people who are interested in high risk OB. And I think it's a good thing to be, involved in learning more. We can all learn more. Even, all of us who are doing clinical medicine can certainly learn from each other. And, just going through this kind of rigorous talking about things, I think will definitely improve the care that you're providing to your patients day by day. And then, the HELLP 2023. So, it's kind of interesting that I met Revati in one of the HELLP meetings that was in, I think, New Orleans in US. And they were just like, we really sat across the table and we were like, oh, what can we do together? And I became the global co-chair for the co-chair for the global committee for HELLP. And one of the things that when I did that, this was in 2019, we kind of sat down and we said, what can we do? And I said, maybe we can do an educational program, which we kind of did that. And that was our PenI program. And then the second thing, I was like, maybe we can take the conference to Southeast Asia. And they were, obviously we were lots of planning on Revati and Dr. Mehta, but obviously they agreed. So that will be actually really nice. Yeah. So if you guys can participate, I think we're going to have a hybrid kind of a conference, but being in person is something different. You can meet so many people. Pretty much a lot of people are going to come. The HELLP president, Dr. Laura McGee, she's a good friend. She's going to come. Dr. Karamanchi is going to come. So a lot of like big people in the field of pre-eclampsia are going to be there. So I would highly recommend, if you can, you should definitely come. So without taking too much of your time, I'm very excited that we are going to talk about, I think, HELLP syndrome and severe preeclampsia. And it's early in the night, so I'm happy to stick around for the panel discussion. So welcome, everyone. Thank you for welcoming me as well.
Now, I would like to invite Dr. Sushma to talk about HELLP syndrome, one of the commonest problematic severe preeclampsias. Dr. Sushma, over to you.
Good morning, everyone. Thank you for that introduction. I'm just sharing my screen. Is my screen seen, Dr. Anu?
Just make it full screen. Yeah, that's fine.
Seen, sir. Thank you, sir. Today, I'll be speaking about HELLP syndrome. HELLP syndrome is a severe form of preeclampsia associated with hemolytic anemia, elevated liver enzymes, and low platelet count. It's usually seen in the second half of pregnancy. I say usually because not all, at least 20% of them are seen in early pregnancy, which is an atypical presentation. Any patient who is diagnosed with HELLP syndrome, should be considered to have severe preeclampsia and need to be watch out on that. So the incidence of HELLP syndrome is around 1 to 2% of all pregnancies, and 10 to 20% of severe preeclampsia gets complicated with HELLP syndrome. They usually present in the second half of pregnancy or immediate postpartum pain. Significant new onset epigastric discomfort or right upper quadrant pain. So the clinical features are right upper quadrant pain around the stomach. So it can be mixed with other medical conditions like appendicitis, nausea, headache, malaise, and signs like right upper quadrant tenderness, elevated blood pressures, proteinuria, and edema. Why are we so much speaking about HELLP syndrome? Because of its high rates of mortality and morbidity. So it's one of the rapid, it progresses very rapidly, and the maternal and fetal condition deteriorates very fast. So the maternal mortality rate is up to 1 to 5%, whereas perinatal mortality is up to 35%. Maternal morbidity is around 20 to 25% due to DIC, placental abruption, hepatic subcapsular hematoma, acute renal failure, pulmonary edema, cerebral hemorrhage, and stroke. Fetal morbidity and mortality is because of placental abruption and IUFDs, intrauterine asphyxia, prematurity, and fetal growth restriction, which is usually in association with severe preeclampsia and thrombocytopenia. So as previously said, the diagnostic criteria in hemolytic anemia on peripheral smear, we see schistocytes, Burr cells, RBC fragments, elevated bilirubin of more than 1.2 milligram per deciliter, absent plasma haptoglobulins, elevated liver enzymes, that is SGOT, anything more than 72 international units per liter, and LDH of more than 600 international units per liter. And low platelet count of 1 to 1.5 lakh. So the risk factors here are elderly gravida, a special emphasis on ART pregnancies on donor gamete. They are at a high risk of atypical preeclampsia, and they can present even before 20 weeks. So we should be on watch out on such pregnancies. Multiparity, white race, and poor pregnancy outcome histories. It has been classified into two types of classification. One is based on the severity, and the other is based on the number of lab parameters involved. So the MSP classification is based on the platelet count, the liver enzymes, and LDH. And platelet count less than 50,000. 50,000 to 1 lakh and 1 lakh to 1.5 lakh. It is severe, moderate, and mild. And liver enzymes, anything more than 72 international units is class 1 or class 2, that's severe or moderate. And at the borderline, that is anything more than 40 is mild. LDH, anytime more than 600 international units is said to be HELLP syndrome. So the next type of classification is Tennessee's classification, which is which says about complete or partial HELLP based on the lab parameters. If all the parameters are involved, it's called complete HELLP syndrome. That is elevated liver LDH, increased bilirubin, AST, ALT, and low platelet count. But in partial HELLP or the atypical HELLP, it can present in less than 20 weeks of gestation with or without hypertension and proteinuria, usually common in plural pregnancies and ART pregnancies. Hence, they are at a high risk in association with severe preeclampsia. So what are the differential diagnoses which can confuse it with other medical conditions are biliary colic or cholelithiasis or appendicitis, idiopathic thrombocytopenic purpura, GERD, peptic ulcer disease, acute fatty liver of pregnancy, dengue in pregnancy, and HUS, hemolytic uremic syndrome. Why are we so much worried to know about the proper diagnosis is the management varies in each condition. This is a small chart to say how we differentiate HELLP from other pregnancy-related conditions which can mimic HELLP syndrome. Complications are eclampsia, abruptio placentae, DIC, acute renal failure, severe ascites, cerebral edema, pulmonary edema. Lab tests. So if a patient comes with HELLP syndrome, we have to do certain set of lab tests to get to the diagnosis. That is complete hemogram and to see for the peripheral smear for histiocytes and bursals, low platelet count, features of hemolysis will be seen. Then elevated liver enzymes and bilirubin, elevated LDH. As HELLP syndrome is always associated with severe preeclampsia, look for proteinuria, elevated uric acid, and other parameters like low haptoglobulin. And if the patient is getting into DIC, low fibrinogen level, elevated D-dimer assay will also help. So the next newer thing is the biomarkers. They help in predicting and prognosticating the process. So in recent studies have shown that SFLT1 and PLGF ratio can help predict severe preeclampsia and HELLP syndrome. So based on its sensitivity and specificity, early onset preeclampsia have a high sensitivity of 94% and specificity of 99.4% in predicting HELLP and severe PE, and late onset PE with a sensitivity of 89.5% and a specificity of 95.4%. And they are on further research. So how do we manage such a patient? When such a patient comes to the hospital, preferably such patients have to be treated in a tertiary care in a HDU or a ICU setup where blood and blood products, ventilatory support, and are available. At the time of admission, there should be a proper consent. The patient and the relatives have to be explained about the risk, morbidity, mortality associated with such a condition has to be explained to the patient. And to say how the patient gets stabilized, the basic ABC, that is airway, breathing, circulation, has to be followed. That is to start with an IV line, start with IV fluid, 75 to 100 ml per hour, intake output chart, then intensive monitoring of maternal and fetal parameters, that is maternal parameters to look for any reflexes. Lung base has to be looked for any pulmonary edema, look for the vitals, look for her blood pressures, and start antihypertensive according to the clinical picture. On fetal monitoring, it is we have to look for CTG, then look for Dopplers to look for fetal well-being, abdominal scan to look for any subcapsular hematoma in the liver, then antihypertensives to control the blood pressure in the mother, Then magnesium sulfate, if the patient is a severe PE getting into preeclampsia or eclampsia, then steroids for fetal lung maturity. And it is also said that it helps if dexamethasone is used, it helps in platelet stabilization to prevent thrombocytopenia. Then serial lab tests to see how the disease is progressing or halting at that point. And blood and blood products need to be arranged and an informed consent as previously told. Delivery plan is if the patient is unstable, needs to be delivered immediately. And if it is more than 34 weeks and stable, they need to be. We need to consider delivery in 24 hours after the fetal administration of steroid for fetal lung maturity. But less than 34 weeks and stable patient, administer steroids, reassess after 24 to 48 hours, and then based on the situation or the clinical parameters, further decision needs to be made. Vaginal delivery is not a contraindication, but cesarean is done only for obstetric indications. In case of cesarean section, general anesthesia is preferred over regional for if platelet count is less than 75,000. And if anything less than 50,000, 6 units of platelet needs to be transfused. And at the time of section, during the time of closure, proper hemostasis has to be achieved, and preferably a drain to be left so that if there is collection, it can be drained out. And during postpartum, we need to look for serial lab parameters to see whether patient is progressing or getting into normalcy. Antihypertensives to be adjusted as after in the postpartum period, the disease to some extent comes to control. If it is a postpartum HELLP, which is around 20% of incidence, the same thing follows, that is stabilizing the patient and multidisciplinary approach in a tertiary care center follows, administering of steroids and antihypertensive, Maxalv and blood transfusion will be followed. Thank you.
Thank you so much, Dr. Sushma, for such a crisp and very nice presentation. Now we would move on to the panel discussion on severe preeclampsia. Before the panel discussion begins, I would request Dr. Prakash Mehta sir to give a brief introduction to the topic severe preeclampsia.
Good morning once again, everybody. Preeclampsia, when I was a postgraduate student, was something that was very simple. All you need to do was to check on edema and blood pressure and urine albumin. We had a side room where we would do a urine albumin and say, okay, this patient has got preeclampsia. And the only problem that at those days we were worrying about was eclampsia, since magnesium sulfate had not yet come into India and we were using Menon's regime for treating eclampsia. So our worry was mainly eclampsia rather than preeclampsia. Now, over the last few years, a huge transition has occurred. Today, if I have a patient with eclampsia, I can manage her very easily because I know that it is going to be, I give magnesium sulfate and she's going to be fine. Even if she throws repeated convulsion, I give some extra dose of magnesium sulfate and she's going to be fine. Even if that worsens, I give her a thiopental, knock her out, put her on ventilator for 24 hours and 24 hours later, she's going to be absolutely fine. But as far as preeclampsia and severe preeclampsia is concerned, lots and lots of changes have come in, and it is very, very difficult to identify which patient is going to give me problem. Now, every week I have about a dozen patients either referred to me or discussed with me on phone as to the complications of the severe preeclampsia, where there were absolutely no clue whatsoever that this patient could worsen. I'll just give you 2 or 3 simple examples. One patient who had a blood pressure of 140/90 just prior to delivery. Post-delivery, her BP remained 140/90 for about 24 hours. After that, the patient settled down. Now, because the patient settled down, the concerned obstetrician thought that it was okay to discharge her on day 3. So she was discharged on day 3 without investigations, mind you, because BP has been only very mildly raised. On the 4th day morning, the patient came with repeated attacks of convulsions, so bad that she actually suffered a cardiac arrest. We had to call a cold blue in the hospital. Somehow we could revive her, put her on a ventilator, and ultimately the patient settled down and went home well. So that was one case. The other case that we had was a patient, again a BP of only by 140/90 for just about 24 hours prior to the delivery. The patient was induced, a forceps delivery was carried out, and about 2 hours after delivery, patient landed up with massive postpartum hemorrhage. When the patient was investigated at that particular time, she was referred and then investigated at that particular time, we found that she had HELLP syndrome. The liver enzymes were all in the sky. The PT-PTTs were abnormal. The uric acid was very high. LDH was around 2,500 and so on. The third case was another patient who was, again, only a single BP reading on admission of 140/90. After that, the repeat BPs all being normal. The patient again underwent a cesarean section for a different indication altogether, and post-delivery, the patient did not get any urine output. So all the fluid challenge test was given, and then the little bit of Lasix and all those kind of things were given, and the patient had after that hematuria. Investigated the patient, and we found that again she was with a HELLP syndrome. So these are the kind of situations where it is extremely difficult to explain to the relatives as to what happened. Because most of the times, quite a few physicians and many of our obstetricians, I'm sorry to say, tell the patient that if the BP is 140/90, don't worry, nothing's going to happen. 140/90 is quite a common BP in pregnancy. Now, we are in an era of atypical pre-eclampsia, and please be careful, because once such a situation arises, the relatives are going to, literally tackle you as to why no care was taken. Now, at the other spectrum, we have, once you have this patient with you, you do some simple investigations. You do a complete pre-eclampsia profile on them, do a LDH. Unfortunately, again, many of the hospitals, when they order a liver function test or even a pre-eclampsia profile, only SGPT, SGOT is being done, LDH is not being done. Please ensure that you tell your lab that an LDH has to be done on all patients with pre-eclampsia whom you're sending for liver function. Okay. Now, another important thing, I'll give you another example of another 3 cases that are lying down in my hospital right now. One is a patient who is 29 weeks pregnant. She had a blood pressure of 160/110 when she was referred to me. Last time at around 27 weeks, she had severe pre-eclampsia, and which resulted in an accidental hemorrhage and an IUD. And now she's 29 weeks, the BP of 160/110, investigated her, found that her kidneys were not normal. There was a grade 2 nephropathy in her, telling me that possibly I'm dealing with a chronic hypertension with a superimposed pre-eclampsia. Now, 29 weeker, yes, I can definitely save this baby in my hospital if I deliver her at 29 weeks. But then just because you got a good NICU doesn't mean you deliver at 29 weeks. You need to carry on the pregnancy as much as possible. So now what do? I did a complete pre-eclampsia profile on her. Everything is normal. But still the worry is always there. The relatives keep on, asking questions and showing their worry. That last time also within 24 hours, 140/90 began, 160/110. She had accidental hemorrhage and we landed up with an IUD. Doctor, are you going to assure us this is not going to happen this time? So now how do I handle this patient? One very simple thing that I did was, I'm sure Revati is going to discuss this a lot in detail when she comes to the preeclampsia. I just did a S-split PLGF ratio on her. The ratio was only 27.5. So, without any much worry, my biochemistry is normal. My ratio is normal. Without much worry, I could tell them, look here, don't worry. I'm going to try to take this pregnancy at least to 34 weeks, if not much. But yes, we need to monitor you every 3rd days. I'll be doing a pre-eclampsia profile. Every week I'll be doing a Doppler. Every 3rd day I'll be doing a non-stress test on this patient. But I would definitely be able to take her up to 34 weeks and ensure that I get her a good baby. The second patient again is almost similar. This time again admitted with a BP of 160, 110. She has already lost 2 babies before. One at 8th month due to severe pre-eclampsia, second one at 5th month due to severe pre-eclampsia, and now her blood pressure is 160, 110. But again, her biochemistry is normal. Yes, this patient got admitted just yesterday. So we have sent the split PLGF ratio, and hopefully I should get it by tomorrow morning. I expect that it should come normal, and if it comes normal, I can again reassure this patient also that I would be taking you further. The third patient is even more interesting in the sense she is a gravida 6 with previous 5 losses. She's a diabetic. She has a large fibroid uterus in the lower segment of about 10 into 12 centimeters. And this time she has got a twin gestation. And that much is not enough. One of the twin has got a AVST malformation. And that twin is showing me a lot of FGR. The abdominal circumference is less than 1 centile. The CPR is less than 1 for that one twin. Now, again, these kind of patients, her blood pressure stays around 140/90. Her edema, of course, is massive. Imagine a fibroid in the lower segment and a twin gestation. In this kind of a diabetic patient, obviously the edema is going to be much more. A wee bit of albumin is also going to be there. And now she's 31 plus weeks. But because, you do continuous monitoring, I've got much more confidence that I should also be able to take her to maybe 33, 34 weeks. But all this will come at a cost. I always tell my patient that if I deliver you and your baby goes into an ICU, the costs that are going to come to you, the financial implications are going to be very, very heavy. Instead of that, just if I keep you in front of my eyes, keep doing repeated investigations, the cost is going to be only a fraction. On that, you avoid any one of you who have had patients who goes into the baby who goes into NICU and on a ventilator, a 700 grammer, 800 grammer, a 900 grammer. You know that the next 2 weeks are going to be hell, not only for the couple, but they keep on coming on asking you also the questions. How much ever you tell them, talk to the neonatologist, they'll say, no, doctor, you manage my pregnancy. You tell me now what's going to happen. So we should not be giving a chance for this. And, you do a continuous monitoring, manage the patient well. You will be avoiding both the maternal and the fetal complications. And I'm sure Revati has got a wonderful set of panelists. We have got a real senior panelists on the panel who have done a lot of work in the field of pre-eclampsia. And I'm sure that panel would be an eye-opener. Pre-eclampsia has been my passion for the only reason that I get a lot of references for pre-eclampsia. And when you sit down and think about it coolly, you find that the complication could have been very, very, very easily avoided. So somewhere along the way, our mindset, it has got into us that only if the BP is 160, 110 or 180, 120, that my patient can have problem. Please remember, your patient can have problem even if the blood pressure is 140/90, and we need to be careful with all our pre-eclampsias. So with this short introduction, I would request Dr. Revati to start off a panel and enlighten our audience about how to handle a patient with severe pre-eclampsia. Thank you very much.
Thank you so much, sir, for that brief introduction on the clinical aspects of how we actually manage pre-eclampsia with severe features. So let me just share my slides. I'm not able to make it full screen. Just give me a second.
You can click on display settings.
The display settings is not being obvious here. I think I double clicked it. Just a minute. Some problem here. Just a minute.
All right, till Revati sets up her slides. Magnesium sulfate, we all know, is a wonderful drug. Although we have been hearing a lot of scary things about it, about respiratory depression and whatnot, please remember that it is not what we call as a dangerous drug. So please do not hesitate to use magnesium sulfate and use it in the right dose. That is why in our pre-eclampsia, the World Congress of HELLP World Congress in 2023, we are planning to have a full session on how to use magnesium sulfate for severe pre-eclampsia, eclampsia, and how you could handle these cases without too much worry. That would be definitely one of the workshops on that meeting. Are you ready, Revati?
Yes, sir. Actually, the display settings option is not visible on my screen, Sahiti. So
We
Ma'am,
can
it's
see
on
on
top,
display.
ma'am.
We can see.
Display settings. It's
I know
on
I
top.
always did that, but somehow this is not coming. But even when I checked my slides, it was there.
We can see it, Revati. It doesn't matter. You could go
Is
ahead.
it
We can
okay?
see it.
Okay. Is it okay? Can you see it?
Yeah.
Fine. All right. Because I wanted some of the illustrations to come out big on the screen. Yeah, I got this. Yeah, I think I'm set. Is that okay?
Yeah. Perfect.
Yes, sir. Sure. And at the outset, I would want to welcome all the esteemed panelists and, of course, the expert reviewers, Dr. Prakash Mehta and Dr. Sarosh Rana. So let's take off with the case. Now, this is something that happened in my clinic, and I definitely want to bring it to the notice of all the audience and, what we did to overcome, the problems of a lady who had sustained preeclampsia with severe features and had problems. So this is going to be a case-based discussion because we want to really discuss about how to manage cases real time, because it's not in the books, it happens in the clinic. So how are we going to do this? So let me start off with the case. She was a 33-year-old. She was gravida 2, para 1, live 1. She was natural conception, previous cesarean. She was singleton pregnancy, presented to my OPD at 28 weeks and 4 days for evaluation. So she met me only in the 3rd trimester. And her major concerns were she had history of increased mean uterine artery PI on scan between 22 to 23 weeks of gestation. The mean PI was also informed to be high for gestational age between 12 to 13 weeks of gestation and has been on aspirin 75 milligrams once daily since then. Now, she gives history of previous preeclampsia with severe features and severe fetal growth restriction with iatrogenic preterm cesarean at 36 weeks, which was, and then finally a 1.6 kg male baby was extracted, which was stabilized in the NICU for about 3 weeks and discharged. The baby further had delayed milestones and also developed a seizure disorder. It was partial seizures, and MRI brain confirmed involvement of the occipital lobe attributable to the seizure disorder, and probably it was a hypoxic insult. Now, on examination, the patient was normotensive. That is, when she presented to the OPD, the BP was 120 by 76 mmHg. She was impaired glucose tolerance based on her GTT that was done previously in her antenatal record, and was on thyroxine supplementation 50 micrograms once daily for subclinical hypothyroidism. Clinically, patient corresponded to about 28 weeks with cephalic presentation with a relaxed uterus, perceiving fetal movements well. Scan was done and it corresponded to 28 to 29 weeks of gestation. It was a cephalic presentation, adequate LICA. The fluid was about 12.8 centimeters. Placenta was anterior and not low-lying. Uterine artery Doppler mean PI at that time. We usually do not do it in the 3rd trimester, but because she had presented to me like this, and her concerns were because she was previous, preeclampsia with severe features, and she was emphasizing on her uterine artery Doppler being still high, and she was aware of the fact that it could mean a sinister sign, and she would probably evolve into preeclampsia, severe features, in spite of being on aspirin 75 milligrams. So when we did it, It was 1.99 and higher limit of normal. It was almost at the 90th centile. Fetal Dopplers, umbilical artery Doppler PI was 1.28, and again, it was on the upper limit of normal, and the other Dopplers were within normal limits. Her CTG at booking was also within normal limits. Relevant investigations at booking, these were biochemistry. Complete hemogram was normal, but platelet count was 1.8 lakhs per cubic millimeter. TSH was 2.01 micro international units per ml. I investigate patients with subclinical hypothyroidism with TPO antibody, and incidentally, she was also positive for the TPO antibody, and she was 48.6 units per ml. HbA1c was 4.7% at booking, and GTT 75 grams as per her antenatal record was 133 milligrams. So she was impaired glucose tolerance, and this was performed at 24 weeks of gestation. Liver function test and renal function test was within normal limit, and urine routine micro was normal, albumin was nil. She also showed me that, she had a LA report, that is the lupus anticoagulant, which was negative. The complete APLA profile was not done because according to her, because she had a history of one previous pregnancy with preeclampsia with severe features, and what was done to her was lupus anticoagulant, and she assumed that she was APLA negative. I don't know why TORCH was done. TORCH was done and it was negative. This was what she has shared from her antenatal records. And she also showed me that her combined test for aneuploidy, which was done in the first trimester, was, there was nothing significant. It was within normal limits. Now, my concern as a clinician, she's approached the maternal fetal medicine specialist out of concern. She did it on her own because she is really worried. Last time she had preeclampsia with severe features, like how sir said, the evolution into the severe form of disease was very soon. So she's really concerned. And her uterine artery mean PI continued to be very high, 90th centile, in spite of being on aspirin. She's also concerned about her risk of developing preeclampsia with severe features, which could suddenly evolve, resulting in an iatrogenic preterm like last time with neonatal complications. Now, as a maternal fetal medicine specialist, how would you want to counsel this patient and manage further? And what do you think there is a role of biomarkers after all the discussion? Because we definitely want to do away with only consequence management. Let's do something predictive. Let's do something prophylactic. Let's save our mothers from criticality. So do we really have any role of biomarkers for prediction for preeclampsia with severe features? Now, this question is to Dr. Harini Shetty. Can you please answer this?
Hi, Dr. Revati. This is a very interesting case where there is the previous preterm birth, that too by C-section, and the history of severe preeclampsia, and even the live birth, but the baby has a seizure disorder and milestone delayed development. So this case has to be taken very seriously as a fetal-maternal expert. Basically, the first thing is when she has come to your OPD at 28 weeks of 3 days, the clinical examination of the patient is very important. The first you check for her the blood pressure, that confirm that it was 120/80. So then it is better to send her for the thorough the fetal well-being scan, including the uterine artery mean PI with the fetal Dopplers to confirm that there is any IUGR or the Leica amount also, if there is a decreased Leica also. Apart from that, whatever the fetal well-being scan has been done, so apart from the uterine PI index was high, the other parameters of the fetal parameters were normal. So I would like to go for this extended, that is, as you know, the preeclampsia cause for these people are immunological basically. So extended APLA and the thrombophilia profile, I would like to ask for this patient. Apart from that, complete PIH profile, as you say, complete hemogram, APTT-PT, INR, and renal function test, liver function test, including LDH and the peripheral smear. And as you say, like her APLA, if you see extended APLA when you did her anticardiolipin antibodies and B2 glycoprotein IgM was positive, and plus ANA was positive. So that's why extended ANA profile we will advise for this patient. Once this extended ANA profile, when you have done, the test shows that ANA profile is positive, but anti-TPO is only positive. Apart from that, extended ANA profile came negative, but in spite of this patient was on ecosprin 75 mg, it's better to take an immunologist advice also at the same time, because extended the profile was high. That is why the risk modulation was done in this case. Adding low molecular weight heparin with the ecosprin was increased up to 150 mg. Along with that, HCQs was started as an immunomodulator because her ANA anti-TPO was high in this case. So now when you know about this part, pH part is okay, the profile is fine, but I feel in spite of starting low molecular weight heparin and ecosprin, I would like to advise PLGF SFLT markers. These biomarkers gives us in this type of cases how long we can wait and what is the prediction for getting a PIH or the HELLP in this type of cases. So that even though the test is a bit expensive, in this type of cases, if you deliver, see 28 weeks, 3 days when the patient comes, if you have a very good NICU backup, so definitely you can do the C-section and give the baby to the neonatologist. But here we would like to cut down the expenses and better for the baby's the brain development. At least we would like to push the case 32 to 34 weeks without any problem to the mother and the baby. In this is the scenario. So in this case, we insist on biomarkers. This is the prediction for the PIH. So that's why PLGF SFLT titer is advised in this case. If you clearly look at that, if the PLGF SFLT titer, it was around 28, it came. So when it is less than 36, I think we can wait easily without any, further risk for the baby and the mother. So after 28 weeks, if you are settled, if your all PIH profile shows it is normal, patient is on low molecular weight heparin and ecosprin, and your PLGF SFLT titer shows less than 36. So definitely I would like to take the fetal surveillance and maternal surveillance, at least ask for weekly the blood pressure monitoring and the biophysical profile NST. If it is okay, like again you asked weekly surveillance, I will prefer in this case, even though you may advise like 2 weekly NST and biophysical profile, and once in 3 weeks the growth scan, like especially fetal Dopplers. Since the biophysical profile PLGF SFLT titer is supporting for us, so continue the advice to come after 2 weeks with the growth scan and do NST and again the blood pressure monitoring. So I think again you have done 2 weeks later, again PLGF SFLT titer was advised. So it came around 90 at that moment. So here the intensive screening started, advised the patient to get admitted in the hospital, but patient refused. So you ask for the 4 times the blood pressure monitoring at home and biweekly surveillance with the modified the biophysical profile. So at 34 weeks, if you see, this patient had the growth scan, a lag of 1 week, and the A5 was 12, and fetal Dopplers were normal, and the whole abdominal scan and maternal echo and the ECG and fundus were within normal limit. A week later, that PET profile was repeated, so the platelets started dropping 92,000, and the LDH was 393 and SGPT was slightly elevated. And the PLGF SFLT, the titer was 92.3. So again, the patient was advised for admission. After admission, as you said, the steroid was administered for the patient because in the view of her platelet was down. So then the patient has taken as long as her platelet has dropped to 66,000. So emergency LSES in a high-risk center, it was taken, and with the max sulfate cover. So the basically the delivery option is the LSES has been done, and the baby was okay. In the view of the decreased fetal movement and suspected HELLP, that was the indication basically. And before arranging for the C-section, the blood, like the 2 pints of packed cells and fresh frozen plasma and 1 STP was arranged. And basically the baby weight was 2.2 the kg, and UPGA was good. And in view of anemia, the baby has transfused 1 pint of blood, and baby was discharged after 5 days of NICU. And the baby is around 4 years without any the problems. So I would like to, since the biophysical, this biomarkers were there, so that is the way we would like to take up this case until 35 weeks, 6 days. If the same patient has come to me, the most probably I would have, removed the baby if without the biomarkers help around 32 to 33 weeks of gestation. Once her platelets started dropping, I preferably take up the case with the steroid after inducing a course of steroid, and prefer to do the LSES, and baby would have admitted for NICU more than 2 weeks. So what I would like to emphasize here, biomarkers are the predictors, and how to take, even though I feel biomarkers, the cost is about 5,000 rupees. When you ask for a biomarkers, most of the patients will be scared. Oh, this much expensive. I don't want to do this case. I don't want to do the biomarkers. Then we have to go depending upon the serum uric acid and urine albumin daily or once in 3 days, and look for the platelet and then the liver function test dropping, and then take up. The definitely biomarker has given the role here to take up the case up to 35 weeks, 6 days without the baby getting admitted into NICU. So this is what I'm emphasizing, Dr. Revati.
Thank you so much, Dr. Harini. I think you took through the case, and so I'm not going to repeat it. Yes, I would want to highlight certain points about the case. This lady presented to me with history of preeclampsia with severe features, and there was severe FGR, there was delayed milestones. Her worry was she was gestational hypertension previously, but she evolved into severe features really abruptly, and then finally had a baby which was growth restricted and stayed in the NICU with problems. Now, we all as clinicians understand that uterine artery Doppler is not the only indicator, but in a lady who's had these features and you already had something on the uterine artery Doppler, though uterine artery Doppler mean PI can only pick up about 50% of cases who could probably develop preeclampsia and severe features. See, here we may not, we cannot decide what the patient can come with. The patient may not have a typical combined screen in the first trimester with the uterine artery PI, the MAP, and the PLGF. You have to accept patients who are just going to have anything that they can probably get done. So if this lady has had a uterine artery Doppler PI, there's something sinister about it, and she's telling you that she's had problems last time. We have to take her seriously. The ideal thing to do, if you're going to use the uterine artery Doppler screening, is to do it in the first trimester. Make sure that the map as well as the clinical features and everything else is considered, and use only centile values, because you cannot just say one particular value of the uterine artery Doppler mean PI is going to indicate some adverse outcome. You probably use centiles at different gestations, even if you're going to probably if you're going to use it as a marker to predict problems like preeclampsia with severe features. And we all know that preeclampsia is a heterogeneous disease. There's never a single marker which can probably tell us that, yes, this lady is going to have problems. And we are also very sure that we are going to get patients not necessarily at, in the first trimester. We're going to encounter them at 20 weeks, 24 weeks, 28 weeks, and they're going to have problems previously. So yes, when we have somebody who's not had a proper screen and she's had a history, biomarkers can definitely help us. Just like in this case, there was a lot of counseling involved because she was a well-read patient. She was an IT professional. She understood why she was taking aspirin, and I had to explain to her why I wanted to give her 150. We're going to talk about all this as part of our application questions. And then I even told her that, yes, I need to look at your APLA a little more in detail. And when we actually picked up the root cause, it was slightly easy because we probably added that low molecular weight heparin, which gave her that extra mile compared to her previous pregnancy. But it's definitely not going to be totally preventive of the problem. So we used the biomarkers. We did go up to 36 weeks. And then when suddenly there was this high biomarker for all those who don't use the biomarkers, if the sp1 PLGF is going to be less than 38, then the chances that this lady would develop pre-eclampsia with severe features in the next 1 week would be very close to 100%. That means she will not develop pre-eclampsia with severe features if it is less than 38. But if it is more than 85, the chances that this lady would develop pre-eclampsia with severe features could be about 60%. So this lady had a normal biomarker, which progressively increased as she developed gestational hypertension, and she was very alert about it because she had developed gestational hypertension previously also. And as the biomarker kept changing, she was still stable. She had a platelet count which had dropped, but she did not have any other problems. But she started complaining of decreased fetal movement when she was already in the hospital because I had hospitalized her when her biomarker was abnormal. So this is the most wonderful thing that a biomarker can do. It can probably tell you whom to admit and when to admit. And even if there is going to be a complication, just like in her, because she went up into a kind of an abruption because there was a retroplacental bleed there. The baby had anemia. It was a 2.1 kg, but the baby did not stay in the NICU for more than 5 days. It was stabilized and given back to her. And there was no hypoxic insult because we had interfered at the right time because of the biomarker. So why, I know it is not so easy that we can do biomarkers in every setup in our country, but yes, we need to really look at it seriously and maybe change, because we can definitely make a difference to the outcomes of these women, especially in medical colleges. So this is our surveillance sheets to show you what we did. And this was the last scan that we actually did prior to delivery. This is how the sp1 PLGF report looked like. You can see that 92.3, which is glaring. I can remember talking to the patient at this point of time and explaining to her that she's really prone to adverse maternal and perinatal outcomes. And then we had time to put her into a tertiary care. We arranged blood products. We had the neonatologist. We transfused platelets. We transfused FFP, got the baby out, and the baby is doing well 4 years after delivery. Now, the application questions. What is pre-eclampsia with severe features for the benefit of the
Revati, can I just interject and just maybe make a couple of
Yes.
points?
Yes. Dr.
So
Please
one
go
thing
ahead.
is that I'm unable to understand is, so if I were to see this patient who has a prior history of pre-E with severe features and FGR, I agree. I think a complete antiphospholipid antibody workup should be done, and she should be on aspirin and Lovenox from the very beginning of her pregnancy. So that's one thing. I agree with you guys that even if the Lovenox was started after 28 weeks, I think it's a good idea. One thing I'm trying to understand is, in a normally grown fetus, in somebody with a prior history of preeclampsia, how would the uterine artery Dopplers would have changed her management? So if you have access to the biomarkers, and one of the things that perhaps people can learn from this is, so I don't know if you guys just read the paper that just came out in the New England Journal of Medicine Evidence. I don't know if you guys have access to it, but we just finished a 1,000 patient study, essentially in the US across 10 sites, 12 sites. And we were looking at admitted patients. So I agree this is outpatient, but essentially we were trying to come up with some cutoffs. And we verified that a cutoff of 40, it's a different platform that Roche, has a very high negative predictive value and a reasonably good positive predictive value for prediction of severe pre-E within 2 weeks. Here, though, I think you can perhaps, Revati, just apply your robust study. In an outpatient setting, what we found, Revati did that study, if you have a soluble fluid PLGF of less than 38, you have a 0% chance of developing pre-E with severe features within a week. So I think rather than, I just am able to understand why you would, yeah, this is the one that we're talking about. And if you're higher than 85, you have a pretty significant chance of developing the disease. So one thing, it's a good test to rule out development of severe disease. And in this case, for example, this paper, we only looked for 1 week, but there's actually good evidence that it's pretty good for 2 weeks, especially for development of severe pre-E. So I don't know why you would chase around uterine artery Dopplers and fetal Dopplers in a baby who's well grown. I would not have done that. I don't even have access to biomarkers, so I just do blood pressure monitoring and frequent labs. The other question, which I don't think I can answer right now with the current information, is that we're trying to figure out what should be your first test. So here, for example, you did the Dopplers, I think, first, then obviously did the growth, then you did $1 million workup on all her CBC, LFTs, platelet count. The question is, what are the chances in a patient who has a normal soluble fit PLGF ratio, for example, of 13, to have any evidence of HELLP syndrome at the time or in subsequent development of HELLP syndrome? Again, very, very small. So I know for now, like everybody's doing everything, and you did so much of workup on her. But that's another question to ask, is that if you have a normal soluble fit PLGF ratio, how much you chase around the labs and how much do you chase around definitely the growth ultrasound in a normally grown fetus. Typically, we are not doing it every 2 weeks. And it seems like she had normal blood pressure, so I don't even know what her diagnosis is. I do agree that repeating a soluble fit PLGF in 2 weeks is a good option in patients who have a normal ratio. And if you have a positive ratio of over 85, then certainly admission and delivery based on obstetrical indication. That's what we are saying. So if you read the iShip guidelines, which I was part of writing, we are not saying that the soluble fit PLGF ratio by itself should make any delivery decisions. It should be in conjunction with your other clinical signs and symptoms. So obviously in this case, the platelet count is already 92,000. I would have delivered her, at least given her steroids and admitted her even without the soluble fit PLGF ratio. But having the soluble fit PLGF ratio strengthened the point that she should be admitted, she's going to develop something bad, give her steroids and get her ready for delivery. So I would say that use the ratio to rule out people if it's a low ratio, and then maybe decrease the surveillance. That's what Revati did in her cohort. You can reduce the surveillance of patients and not chase them around. But if it's positive, you can admit them, increase surveillance, and possibly prepare for delivery for patients. So that's how I would use. I'm just confused as to why you were doing such an extensive uterine artery Dopplers and fetal Dopplers in a baby who's normally grown. I don't think there's any relevance in that, definitely not at 28 weeks.
Dr. Sarosh, if I can just answer your questions, I did not want to do it at 28 weeks. She came to me with values which showed that her uterine artery Doppler mean PI was very high, and I had to check it for myself because all her other parameters were normal on her previous scans. She was a well-educated patient. That's why I did it only once. And as a completion, because uterine artery Doppler PIs went high, and I totally acknowledge that it's not at all a significant tool for anybody to actually chase around for preeclampsia with severe features. But I, for completion, checked what was happening to the fetus, because we know that by the time it reflects on the growth, there could be Doppler changes. I just wanted to have a baseline. That's one. And the second thing, this happened in 2018 when the knowledge of biomarkers was really very less in our country. Let me tell you, I was probably doing it alone. And I had to really introduce this concept to my patient. So I had to do all the other tests and tell her that her liver function is normal, her creat is normal, and the other PET profile is normal, and then only go ahead with the FPIT1 PLGF. And then when she understood that, yes, the numbers were normal, I could just proceed with explaining to her that the numbers is climbing up and this is more of a prognostic kind of a test, and the other tests are still normal. So it is really difficult when you use it in a clinical setup with especially a new test. People are aware that we do liver functions, we do creat, we do LDH, we do platelet for PET. Let me tell you, even clinicians, contemporary clinicians do not really accept for a direct SPIT1 PLGF here in India. It is a very difficult thing because it's an extremely new test, and they have to understand how to actually
which is by the way a great point that you brought up. And I think clinicians like yourself are driving this field. So of course, like I don't even use it. I'm just like preaching about it, waiting for FDA to approve it. But one of the strategies that we are thinking of like doing in US is actually to use it in combination till you get comfortable. So over and over and over again, you have to use it, and you have to say, every time I get a negative test, my patient does fine. Every time I get a negative test, my patient doesn't have thrombocytopenia. My patient is not abrupting. My patient is not having an eclamptic seizure. So everybody has to come to that point themselves. I mean, you're lucky you've been using it for 4 or 5 years now, so you're comfortable with it. But I would just, the second point was, I was just saying that we are actually writing a paper with Peter and Laura looking at what is the benefit of getting other tests if you have a negative soluble fit PLGF ratio. I mean, this is a hypothetical paper we are writing.
Exactly.
We're not doing a prospective study. But I think this is a conclusion that each physician has to come to themselves as you integrate using soluble fit PLGF in your practice, as to how much you rely on this test and how much do you use other things. But absolutely, your strategy of using it with other tests is the right strategy to be comfortable with the test, and also just to make sure you're doing the right thing.
Yes.
Hello,
I would like
Madam.
to add a point here. What happens in India, unfortunately, is that superimposed pre-eclampsia and the regular pre-eclampsia are very, very difficult to identify, because quite a few of our patients neither have a first trimester blood pressure reading or a unreliable first trimester bleeding. First trimester blood pressure measurements is what we have. It is very surprising that quite a few of the cases show up with a secondary hypertension of renal origin in our patients. So that is why we always prefer to do, look at around everywhere and try to get the maximum information from whichever test that would help us.
Yes, sir.
Dr.
So
Prakash,
Dr.
can
Mehta,
I
you're
interfere?
absolutely right.
Not well booked.
This is a
Dr.
very
Prakash?
It
critical
is very
point.
unfortunate that patients who have had early onset severe preeclampsia before are showing hypertension now from 20 weeks would not have had an abdominal scan.
Absolutely.
Our scan.
No, you're right. So
only obstetric scan
yeah,
is
so
asked for.
yeah, so even here it's a major problem in patients with kidney disease, patients with underlying chronic hypertension, lupus. In fact, when we looked at the data in this PRACES study in patients who have chronic hypertension, it's actually very much distinguishes in patients who have superimposed preeclampsia versus who are not. So I think you're absolutely right in those confusing scenarios when you're, and here also we have lots of patients who come in their mid-second trimester or early third trimester. For the first time they have hypertension, they don't know, they haven't seen a doctor, they don't really know how. Yeah, so it's a fantastic test in those patients to at least define them by their angiogenic profile and say, hey, whatever is your diagnosis, at least your risk to have adverse maternal outcomes is low if your ratio is low. So I think you're absolutely right. I think in those confusing scenarios when you're trying to distinguish superimposed pre-E from in patients from simple pre-E, and if you don't really know whether the patient's chronic hypertension, it's a fantastic test.
Yes.
Madam, as presently we are seeing hypertension as a atypical presentation. We have 2 patients. As you said, we are not chasing with the tests, but at least these biochemical markers may help to sensitize the patient, the seriousness of a condition. Like example, in one of my patient, PrenI, term pregnancy, BP shows normal, but there is a increased weight gain and biochemical tests also were normal. Finally, she landed up in IUD. Tell me what I could have done. She didn't know the seriousness. I sensitized her so much. This is a atypical presentation. Your BP is normal, but you have put on excess weight gain. Biochemical tests are all normal. So finally, she said, I'll go home, come back. She came with the IUD. The other patient.
So I can tell you for this patient,
Yeah.
we actually have to wait. You have to wait for our paper to be written. We actually divided up our cohort into women who are hypertensive and non-hypertensive. So if, for example, you're evaluating patient for some symptom of preeclampsia, or for whatever reason you're evaluating somebody, even if patients who are non-hypertensive, so who have normal blood pressure, if they have an elevated soluble fit PLGF ratio, they're at significant risk to have adverse outcome, like likelihood ratios of 12.
Yes.
So that paper we haven't not published yet, but that will be very, very relevant in common scenarios where you can just really rely not so much on your blood pressure. So in normotensive patients, actually a high soluble fit PLGF ratio has a very high positive likelihood ratio. So yes, so if you were to measure her soluble fit PLGF, and there's actually data that soluble fit PLGF predicts IUFDs which is related to placental IUFD. So I'm not talking about IUFD related to a cord prolapse or a true
No.
knot or a nuchal cord, but abruption related IUFD or placental related IUFD. Those are very
Yes.
highly predictive. So yes, I don't know if you have access to the test, but I can tell you that if you had measured her soluble fluid PLGF ratio, perhaps it would have been higher, and then you could have done a different management.
Predicted
But there is
condition.
there's actually data that non-hypertensive, normotensive people with a high ratio are also at high risk to have adverse preeclampsia related adverse outcomes, fetal and neonatal.
Yeah.
No, that's the reason why I told in my introduction that when I was a postgraduate, pre-eclampsia was a very simple disorder. From there, now we have moved on to what we call as the normotensive pre-eclampsias.
Absolutely.
And which are showing much more problems than, with a blood pressure of 180, 120 and things like that.
Yes, sir. I think we've had a very detailed discussion. And let me tell you one thing, I'm sure it's going to trigger more conversations. Actually, this lady had a platelet count of 1.1 lakhs at booking. I didn't want to make it very complicated. I kind of suspected ITP in her, and
I was
she
thinking
did
about
not-
the same thing.
All right. I did not really want to actually bring it to the discussion because we will not finish discussing about it. And this lady was not willing to get admitted at 92,000. Believe me, Dr. Sarosh, I had to really tell her that no, there could be a problem because your SPIT1 has risen from 13 to 22 to 80 and 92.3. And then after 6 hours, when I repeated the platelet, it had fallen to 66,000. She believed it only when she had decreased fetal movements. So it was really difficult. So clinically managing.
But look how nice it is that at the time when your SFLIP PLGF was 92, her platelet count is, I agree, like 92 is, okay, it's low, but it's not super low. Her PT, SGPT is 60, LDH is 390. Look, everything else becomes abnormal within 6 hours.
Exactly.
Right? Her platelet count is falling down, her LDH is going up, her SGOTPT is going up, her blood pressures are going up. Yeah. So this is a very good predictor. Like it can prognosticate in the future and say who is that person who's at risk. So this was beautiful management.
And the best part is the labs are going to give you values like LDH of 400 is normal. They reissue reports, which is common to obstetric and non-obstetric patients, or they would give you an SDOT, SDPT, up to say 40 is normal. There's a slight rise, and she knows that she had a low platelet count. It was a very confusing situation. And thank God I was able to do it with the SPIT1 PLGF, and the baby is normal. So I think
the lab values
and
are
just for
one thing.
everybody to know.
The other thing is people don't even order LDH.
Yeah, we don't order LDH here, but I can.
Centers, LDH
it's confusing.
Yes. So
I can tell you though, Dr. Mehta, is that, and I can send this paper to you guys. I don't know, you probably don't have access to New England Journal, but what we found was the area under the curve for soluble fluid PLGF was 0.92 compared to all other tests that were performed. And this was all studies done and observationally done in US. So all the tests are being performed was less than 0.75. So, and then it's definitely performed so much better than your other test. I mean, whether you combine it, it doesn't really get better. So I would say that, you could potentially ignore this LDH of 412, potentially even ignore the SGOT-PT of 80. You're not going to do anything. You just kind of go with your platelet counts are still very important to consider because obviously you did platelet transfusion because it's kind of low and she's at risk for bleeding. But I mean, I think you can potentially in your mind say, I don't really care what her SGOT-PT is. I already have a diagnosis. I'm going to deliver her.
And she made a lot of savings in her NICU costs because she had spent lakhs last time. And this was just a 5 days observation after the blood transfusion. And yes, the baby was not hypoxic. That is something that the ratio did to the baby. All right. So I think we had a lot of discussions. Now, the application questions. Now, this is to Dr. Lalitambika Karunakaran. Madam, would you please summarize what is preeclampsia with severe features and enumerate risk factors for preeclampsia?
There has been a lot of change in the nomenclatures and classifications of hypertensive disorders of pregnancy from time to time. And till recently, preeclampsia was classified as mild preeclampsia and severe preeclampsia. Now the term mild preeclampsia is not in use, but preeclampsia with severe features whenever there is any of the following abnormality. And one important thing is when the systolic BP is more than 160 and diastolic BP more than 110, on 2 occasions 4 hours apart, if no antihypertensive given in between. Actually, now this is considered as preeclampsia with severe feature, whereas in the previous classification, this was considered as severe gestational hypertension. But now there is nothing like severe gestational hypertension. Whenever BP is more than 160, 110, it is considered as preeclampsia with severe features. Then any of the following other criteria if present, then also it comes under preeclampsia with severe features like thrombocytopenia less than 1 lakh per microliter, new onset persistent headache, not responding to analgesics or presence of visual disturbances, impaired liver function, elevated AST ALT when it is more than twice upper limit of normal, persistent right upper quadrant pain or epigastric pain not responding to medication, pulmonary edema, renal insufficiency, as evidenced by serum creatinine more than 1.1 or double that of the previous value. Next slide. And coming to the risk factors for preeclampsia, several risk factors are described, but it can occur even in patients without any risk factor too. But the common risk factors are nulliparity, multifetal gestation, preeclampsia in a previous pregnancy, chronic hypertension, pregestational diabetes, or even GDM, thrombophilia, either hereditary thrombophilia or acquired, primary EPLA or secondary EPLA, secondary to autoimmune diseases like SLE, pre-pregnancy BMI more than 30, maternal age more than 35, chronic kidney disease, obstructive sleep apnea, pregnancy after ART, and new paternity are risk factors for preeclampsia.
Thank you so much for that elaborate information, Dr. Lalitambika. That was really enlightening. The next question is to Dr. Hemapriya. Need for risk stratification, because you cannot lock in every patient just because she's hypertensive, nor you can let go of each and every patient. So do you think we have to risk stratify these patients? And of course, do the biomarkers have any role?
Yes, I think there is a need for risk stratification because as Dr. Lalitambika pointed out, there are so many risk factors for patients who may develop preeclampsia. So we cannot exactly predict which elderly primey or which primey gravida or which patient with previous history of preeclampsia is going to develop preeclampsia in this pregnancy. So one thing is, yes, careful clinical monitoring definitely will help, but that again becomes like we have to call the patient very frequently if at all we are suspecting that she may be developing preeclampsia. Another thing is what we have been doing for many days, for a long time now is we are doing uterine artery Dopplers quite consistently. So even in the first trimester, along with the NT scan, we have started doing uterine artery Doppler, and uterine artery Doppler PI is definitely helping us, but although it is not very sensitive, so we do have, along with that, we can do either biomarkers or biomarkers alone starting early in the second trimester definitely is going to help. So we will be more vigilant that if the biomarkers start rising and even if the BP still remains normal, probably this is the patient whom we really need to target our surveillance at. So the most common, the good sensitivity is with these biomarkers, SFLT1 and PLGF ratio. So as Dr. Revati has shown in her robust study that the ratio of more than 38 definitely has a higher chance of the patient developing preeclampsia. And so these patients definitely must be under our scanner. Whereas patients who have a normal SFLT-PLGF ratio less than 33 or less than 38 can definitely be just on the lower side of our surveillance.
Thank you so much for that, Dr. Hemapriya. Yes, we need to risk stratify, especially in our country, because we don't have that kind of resources that we could monitor each and every patient. And yes, there are some wonderful papers. We have Dr. Sarosh Rana's paper here, where she's clearly told that, yes, there is a need to stratify women based on the SPIT1-PLGF, and anyone with a ratio of 38 at the triage visit had a positive predictive value of 47% and a negative predictive value of 98% for the presence of severe preeclampsia within 2 weeks. This is a nice paper by Leona Poon, and She clearly says that you can use, this is the idealistic situation. Let me tell you, it doesn't happen with all patients. So you do it in the first trimester, you identify the women who are at risk, start them on aspirin, 150 milligrams, then put them on the S-split1 PLGF. And now this patient of mine is so convinced, she's telling all her friends that it is not enough if you start aspirin, you need monitoring, and that's why you need the ratio in the third trimester. And I've at least delivered 3 or 4 of her friends after I delivered her with the biomarkers. And that's how the message is actually spreading across. Now, this is the very important prognosis study. This gave us this wonderful value of 38. So if you are having somebody who's having a ratio of less than 38, 99.3%, and we have done this in the Indian scenario also, will not develop preeclampsia within 1 week. And the negative predictive value of somebody who had less than 38 within 4 weeks was 94.3, which is still high. And the positive predictive value was about 36.7% within 4 weeks. And in our study, which is the robust study, it was about 60% if it was more than 85 in a week. So this is basically the summary of this. So what I'm trying to say is less than 38 is considered to be normal. Anything above 85 is definitely considered to be abnormal. If you want to have a gestational age-based cutoff, maybe after 34 weeks, use a number 110 because it slightly changes. The ratio changes what is normal after 34 weeks. So maybe, but I personally feel somebody more than 85 is definitely going to be at risk for developing preeclampsia with severe features. And yes, this is the robust study which we've been discussing. So this gave us that confidence that we don't really have to admit a patient if a lady is say above 40 and has an S-split1 PLGF of less than 38. Now, decision to hospitalize, we have this wonderful PRIOS study where you can see here, because I really don't have time to tell you everything about the study, but yes, when you have somebody who, you look at this, this study, they were trying to find out with the ratio and the conventional test, would the decision to hospitalize change. So they had admitted about some patients who were based on the ratio, and they found that 57% of those patients who were hospitalized based on the ratio developed preeclampsia. So this is something that we should probably consider, and this is being used in European countries like the UK, where they stratify patients based on the biomarker. So with this, I would request the expert reviewers to add something. Sir and Dr. Sarosh Rana, do you want to say something?
And Revati, I just sent you the New England Journal paper, so you can read
Sure.
that. It was a little bit different. It was among patients who were admitted, and just pay special attention to the gestational age. It was between 23 weeks and 35 weeks. And also the platform is different, and the ratio is 40 instead of 38. And we just at least in that paper, we just chose only one cutoff of 40 just to say what's the NPV and PPV. To answer your point, actually, for a PRIOS study, we are doing currently doing a study for over 300 patients in US. It just got done looking at exactly this question of decision to hospitalize versus not hospitalize, whether you can revise your decision. Obviously, it's not available here as the tests are not available. So we are doing it in a kind of by design. We will go back and kind of see what happened to the patient and then kind of make a judgment if we were to know the knowledge of the biomarker. So we have certain educators who's going to educate whether the patients can be hospitalized or not. I think I wrote a paper around this concept too, just to show that if you were to use the biomarkers, you will end up hospitalizing much less patients. And among the patients that have a high biomarker, majority of them will actually develop some sort of an adverse outcome. So there is not this one. I think there was a separate paper I wrote about very recently about hospitalization versus not hospitalization. I'm just hypothetically looking at this. So I think you can definitely, in your own practice, see that if the biomarker levels are low, you can really kind of, and then look critically at the cost of surveillance, what you're doing in terms of admitting everybody. So you can definitely stratify them, not just to predict what's going to happen, but perhaps make some simple decisions, such as maybe the person with a low ratio can be surveyed at home. She can come for NSD BPPs, but she doesn't need to be admitted. So certainly a very kind of crucial question. The other question that we are really asking is the use of betamethasone. We typically just routinely give betamethasone to everybody. between 24 and 34 weeks. So perhaps if you have the biomarker information, you can even time your betamethasone. All of us clinicians know that a lot of time we give the patients betamethasone and we don't deliver them within 2 weeks. So then the effect of betamethasone is gone. And then you can rescue them sometimes. And then next time you don't have time to rescue. So there's lots of commotion. So we're actually, in our PRECIS data, we're looking at how can we time betamethasone within 2 weeks of delivery if we were to have the biomarker information. So something you guys can also, obviously using it clinically, you can see, okay, you can potentially time your betamethasone if her soluble for PLGF ratio is high, even if everything else is fine, because she's probably at higher risk to have delivery, even delivery within 2 weeks. I know you didn't really show that data, but delivery within 2 weeks also tracks along the biomarker level. So patients who have a low biomarker have a very low probability of delivering within 2 weeks compared to patients who have a high biomarker level.
Thank you so much.
I'm going to stop here because I can talk for like a whole day about soluble PLGF ratio, but I'll stop here.
Dr. Hemapriya, just continuing from there, cost for surveillance versus critical care expenditure, because I had to talk about this to the patient in detail. Thank God she understood. But do you think this is very important for a clinician to tell the patient what you're trying to do with maybe like a biomarker surveillance and how she would be protected against all the expenditure that she would probably have to invest if she was going to go into critical care?
Yeah, one thing is, yes, since the investigation is costly, every time you do it, she has to shell out somewhere around 5,000, 6,000 rupees. So in that way, yes, many of our patients, especially in the Indian setup and especially in a low resource setting, in a medical college setting where they have to pay for this investigation, yes, they may be initially reluctant to get this done. And once we say that even if we do this ratio, we are still going to do all the other lab parameters to ensure that everything is normal. So in those settings, patients may be a little unwilling. But then once we explain to them the other invisible costs which are there along with hospitalization, they will be losing their work days, they will be losing their income, someone has to come and stay with the patient. In all those ways, if we practically explain to them, probably this works out much more sensible for the patient as well as for us, as well as along with the stress of hospitalization to the patient. Definitely, yes, unless we sit and talk to them and really make them understand the value of these investigations, then probably we may be getting a more positive response from the patients, one thing. And second thing, yes, definitely it helps us to make a decision on when to deliver. That is probably the most important thing which we can counsel them, that if at all the ratio is normal and we can still avoid termination of pregnancy and save on the NICU expenses for the baby, not only the expenses, but also the problems of delivering a preterm baby, which are going to be there lifelong with the baby. Probably baby may be neurologically impaired, they have developmental delay, all those things. If we really make the patients understand, then probably yes, the acceptance is definitely going to be more. And also the cost factor, definitely there is going to be a lot of savings in the cost, not only for the patient but overall as well.
Yes, thank you so much, Dr.
Yeah, so this study that we did in the US, I think the way that you look at it is that it really reduces your false positive. So false positives are the patients that you are saying you are at risk to have preeclampsia, or really nothing happens to her, right? Those are majority of the patients. I mean, not everybody is dying from preeclampsia, right? This is still the prevalence is 8%, 10%. Majority of the patients don't even develop preeclampsia. And even among the patients who you're evaluating, only 30% of them will develop an adverse outcome. So the job here is to find really the patients who are really at high risk so that you can really focus your energy on them. So what you can tell your patients that it tremendously reduces, if you look at the right side, the US is the data that I produced, is that it really reduces your false positive rate. So you're not going to falsely label the patient that you are at risk when she's really not at risk. So you can reassure her and tell her that she's really, and the flip side is that it increases the true negative. If the test is negative, that truly is negative. It's much more informative than just saying your blood pressures are normal, because with a normal blood pressure, you can still have an abruption or preeclampsia within a week or two. So I think what you have to tell the patient is that there will be cost savings. If you're not labeling everybody as having at risk, you will perhaps reduce the surveillance. And if a true negative test really means true negative, you will perhaps not intervene and do preterm deliveries on them because you're so worried about them. So, and then this one did not even include the cost of actually, it didn't really include the cost of NICU savings that you can potentially do. And obviously, like you were saying, short-term, long-term, but even short-term NICU stay every day is super expensive, even in the US. So I think this like cost savings of $1,000 per patient, you can do a cost analysis in your institutions. I can tell you with the frequency of tests that we do, the CPC, CMP, NSTs, BPPs, that will tremendously reduce. I mean, obviously you have to get used to the test, but that's the true meaning here. You have to tell them that it's going to reduce your anxiety because I'm going to tell you if the test is negative, it has a very high, increases your true negative rate and reduces your false positive rates.
Thank you so much, Dr. Sarosh. That was very, very comprehensive. That the next important question, role of postpartum surveillance. We know that about 0.3 to 27.5% is what the prevalence of postpartum hypertension. It looks like a big window, 27% in some times. That is, we are trying to look at patients who can develop pre-eclampsia in the postpartum period. So everything is not over after the patient is discharged. What Sir was trying to say, somebody was discharged on day 3 and she developed postpartum eclampsia. So is there a role of postpartum surveillance, and what do you think are the most important, what do you say, the steps that we should probably take to identify those women who could be at risk?
Yeah, these days we are coming across with postpartum eclampsia, Dr. Revati. But what I emphasize on this patient is basically you have delivered her around 36 weeks, 5 days. So the look for her routine, the platelet count, and look for her daily monitoring of the blood pressure for 3 to 7 days of postpartum period. And see that all the antihypertensives, whatever you have started, that has to be continued at least for 7 days, and keep her diastolic blood pressure less than 85 millimeter of mercury. A week later, you can repeat her all the profile like urine albumin and the blood pressure and the blood count, like whatever platelet and liver function test and creatinine. And if it is normal, I think you can try to discharge this patient. And the day of that, whatever the analgesics also very important. So in this type of patients, better to avoid non-steroidal anti-inflammatory drugs. But if the patient is not, happy with the routine analgesics, apart from non-steroidal anti-inflammatory drugs, if it is not helping, then if there is no AKD, then you might use this. You may prescribe this non-steroidal anti-inflammatory drugs. The breastfeeding definitely to be continued, and then counsel for this patient at the time of discharge that there is a chances of getting gestational hypertension 3% in the future pregnancy, and getting pre-eclampsia at least about 15% in the future pregnancies. So then when the patient, advise the patient to monitor her blood pressure at home and maintain at the diastolic should be less than 85. And if a BP is under normal, then you call her 2 weeks later. So again, check her profile once again. And 3 months later, you can again do all the profiles. If her blood pressure is still persisting and proteinuria is persisting, so advise them to take a physician opinion. So it 6 weeks later, the most probably the chances of getting postpartum eclampsia is not there. So it most probably related to the chronic hypertension could be the cause. So 6 months, and about contraceptive advice also you can do at the same time. And the 6 months later, again, you review the patient. If her the BP is again, if it is the more than 120/80, so then the lifestyle modification and further evaluation with the physician is accepted in this type of patients.
So what you're trying to emphasize is the first week is very, very crucial. It doesn't end on post-op day 3. It goes much beyond that. Look at the blood pressures. They could have new onset postpartum hypertension. I think Dr. Rana has published several papers on that and even the monitoring protocols. And let me tell you, if the androgenic biomarker is high antenatally, these women can develop postpartum hypertension as well. We have seen it in some of our patients, and this is something that we can actually consider. And yes, at the end of 6 weeks, you will reassess her, and it's not just about pregnancy, and then counsel her for her, keep her on a radar because she might be prone for cardiovascular complications later. So do you want to add on something to this?
Yeah, the only one comment I had, I would be very wary of using non-steroidal anti-inflammatory agents in these patients, because some of our pre-eclampsia patients, are very sensitive to NSAIDs, and the renal failure gets precipitated much faster than in any other kind of hypertensive patients. If the patient doesn't respond to, let's say, what you're giving, like maybe paracetamol infusion, she's not responding, then what I use is fentanyl. You give fentanyl, even if it's along with magnesium sulfate, no issue, nothing happens. And use fentanyl, it will work beautifully. Yes, quite a few of them do come up with a paralytic ileus on, second day evening or third day morning, but that settles down with time. So I wouldn't.
I have a question. Are you guys using Lasix for these patients postpartum?
Not as a routine.
Ma'am, I will emphasize one patient, like what I have discussed with Dr. Prakash Mehta also. She's an elderly, the second gravida. So we have not done the PLGF SFLT for this patient because her BP was throughout normal. Her liver function test, we asked only in the later stage. The all CBC profile, everything is normal. So I have taken for elective LSCs because of the CPD. So when I did a C-section, everything was fine. There's no additions. Bladder was okay. Ureter was okay. Everything was fine. But when I finished my C-section and when I came out, there's hardly any urine. There's no urine output. So I was confused, like what's happening? So I thought must be our catheter is in the vagina. So we changed the catheter. Directly frank blood came, around 5 ml of frank blood. We were wondering what is the reason for this? So I thought that there's something, ureter is gone or something like that. Then my anesthetist started a Lasix. With that, blood-stained urine started coming. And by 2 hours early, that the urine output was what, 500 ml. It was a blood stain. Then again 2 hours later, again 228 ml of clear urine started coming. So then we asked the liver function test, except as you say, LDH was missed in this, but liver function tests were slightly elevated. Then I called Dr. Prakash Mehta, sir, I'm confused in this case. There's something going wrong. Like BP is absolutely normal. Pulse is normal. She's not bleeding. So I'm not able to understand why the urine output is not coming. Sir said, Harini, it is an atypical HELLP. So immediately asked for an LDH and the creatinine was normal. So then we started her on max sulfate, then her urine output has improved. So in these type of cases, we have then she recovered 2 days later, urine output is good. But my physician insisted that this patient has to be on Lasix because her output was not good.
So there is a large randomized control trial done that in patients who have preeclampsia, including superimposed preeclampsia and gestational hypertension, patients were randomized to Lasix, PO Lasix. I'm not talking about IV Lasix because your urine output is low. PO Lasix that gets started within 24 hours of delivery. And there were certain inclusion criteria. Patient doesn't have to have an AKI and all that. Anyway, you start Lasix 20 milligrams per day for 5 days. And that led to reduction in postpartum blood pressure. So I can send you that paper, but you can incorporate that into your postpartum
started,
protocol.
20 mg tablet twice a
per day. So we are
days.
actually giving, so the way we manage our postpartum hypertension is a little bit different. So we are not talking about, I'm not talking about IV Lasix because of oliguria. We're talking about in normal people who have normal urine output, have a diagnosis of preeclampsia. We are giving them Lasix 20 milligrams starting on day 1. We typically, for 5 days, we typically discharge our patients on day 3, but we have a very robust program. I published that in Green Journal. We send the patients home with a blood pressure monitor and we do remote patient monitoring through a centralized system. So it's actually very plugged in program, but you can you can, if you're discharging your patients early, I agree with you. You have to do home blood pressure monitoring, because day 3, day 7 is when the blood pressures go up. So they'll come back with, but this Lasix paper actually showed that giving PO Lasix just kind of reduce the postpartum blood pressures and also reduce the readmission rate. So a lot of patients in our hospitals are coming back for severe hypertension readmission. So look at that paper. Perhaps you can incorporate routine use of Lasix in your patients who have preeclampsia. I can send it to you, Revati. It was a very beautiful RCT done. It was published in the journal Hypertension. So it was a very recent study about about 2 years ago that was published. Besides that, we wrote these guidelines for the iShip. So I agree with most of them, except for our patients. I'm still giving them NSAIDs if they don't have AKI, because there's like a big, we don't give narcotics almost to nobody. So lidocaine patches and NSAIDs are the way to go. But if your patient population, I think they may be different. If they are more prone to have AKI, please do not use NSAIDs. But besides that, I agree with everything that you were saying.
Dr. Sarosh, are you putting it in the chat right now, all the articles?
No, I sent it to in an email. I can't
Sure.
attach it to the chat. It doesn't allow me.
Sure.
But I sent you the,
and
I sent you some other.
Yes. So
yeah, you can send it to other people.
Yes. Sure. Thank you so much, Dr. The next important question is about recurrence risk and prevention. Just like this lady was worried, she knew there's something wrong. She's probably going to develop the same thing again. So I'm going to call Dr. Rajni Uday. Can you please enlighten on this, madam?
Yeah, thank you, Revati. Thank you. Yeah, definitely when the patient has gone through the pregnancy of the first nightmare pregnancy, she'll definitely ask us this question, whether she can have the next pregnancy with the same complications. As we all know that gestational hypertension, if they have 25% and pre-eclampsia of 4%, whereas prior pre-eclampsia may develop either gestational hypertension of 5% and pre-eclampsia of 15%. So all of these women definitely will have small gestational babies. That we had to accept it. We have seen it also. We have seen it with prior hypertension in the pregnancy. Even though the BP is normal in this pregnancy, still they can have SGA babies. So the recurrence risk can be modified by the additional risk factors. If she's having additional risk factors are there, definitely it will be more complicated. So we need to explain the risk, and the recurrence, it may go up complications can go up to in more than 50% of the patients. So we need to have the risk factors. What are these risk factors? Major risk factors and the minor risk factors. What do we have? Now, so in the major risk factors, you have to have the maternal characteristics as well as the clinical characteristics also. So any one major factor or any two moderate factors. So major factors, what are those major factors then? As in the first discussion where they said about the modified APLA. So now we have to take care of that modified APLA, and we are seeing quite a lot of the autoimmune problems now. I thought immunology is one thing where we had to creep in and develop and see because it is one of the major factor which is affecting this hypertensive disorders. So chronic kidney disease, diabetes mellitus, that is co-sisters like we are seeing now, as in your case also, she had a diabetes mellitus, Revati. Yes. She had in your case a diabetes mellitus. Yes. So chronic hypertension, and one more thing, multifetal gestation because of the IVF pregnancies, what we are seeing the multifetal gestation. So any other two moderate factors like a first pregnancy, if it is more than 40 years, now we are seeing, I think so, that's pregnancies after 30 and between 30 and 40 are becoming common now. And less than 90, I think so, it has come down. And interpregnancy interval of more than 5 years. That's also one of the reason where the population is deciding upon not to have, we usually tell the patient with the cesarean gap of 2 years. They immediately say, no, madam, we'll go for 5 years. So that's a common thing. So any moderate factors and BMI at first visit, that is more than 35 kgs per meter square, or family history of PE or in vitro fertilization and primary paternity. These are the risk factors. So this maternal characteristics with the history, with the modified medical problems, what they definitely have, we should have the screening algorithm for the pre-eclampsia. Then if they are screened positive, as you are calculated the maternal characteristics with the mean arterial pressure, uterine artery Doppler, then if they are screened positive, offer the first trimester combined screening tests. So the secondary prevention, or what is this is the secondary prevention strategies we need to adopt to. Now we need to modify our treatment where we need to adopt for the secondary prevention strategies. So what is that? So calcium should be administered from 20 weeks of gestation. I think so for Indian-based population, I usually prescribe after the first trimester, definitely iron and calcium is a must. Definitely calcium has a role, especially in hypertension cases. So from 20 weeks gestation, it is effective in decreasing pre-eclampsia risk when administered as high as 1.5 to 2.5 grams per deciliter, or the low dose less than 1 gram per, or a women at a high or a low risk of pre-eclampsia, but only among the population with the low baseline intake of a calcium. Definitely our population requires calcium supplements. We need to emphasize the patient to take the calcium. Even though diet contains enough calcium also, still we need to tell them to take it. Women, I heard that if you take more calcium, the head gets hardened and delivery will be difficult. These are the problems what we listen from the patients. But still, the PE can be prevented. Hypertension can be prevented with this administration of the calcium. So women identified as being at risk of pre-eclampsia, at least one person can be identified for the triple test of multiple variable screening, and the risk of preterm pre-eclampsia more than halved. Or low dose aspirin, or at a dose of 150 milligrams each night from 11 to 14 weeks until 36 weeks, and a randomized control trial where they are shown that 75 to 160 milligrams per day have been studied, and there are no head-to-head trials of different aspirin doses. So aspirin at a dose of less than 100 milligrams is not recommended. I think so we had to change the trend. Still, some prescriptions are there, 75 milligrams. That's what they tell the patient to take once a day. But it is recommended that platelets insensitivity to aspirin up to 40% of the women with the low dose of less than 100 milligrams. So especially we need to a dose of 150 milligram per day or 162 milligram based on 281 milligram tablet of available formulation may be more effective based on the aspirin trial. So finally, the surveillance, where the monitoring the surveillance, we need to have the primary prevention measures and secondary prevention measures for this pre-eclampsia. Revati, anything else?
Yes, madam. I think that was very comprehensive. You highlighted the fact that, yes, we need to give calcium supplementation, we need to give the right dose of aspirin, but we can't do away with monitoring and surveillance, and that's how you can probably prevent adverse outcomes because of the disease. And thank you so much. And yes, we need to tell them about the recurrence risk. Even if you're not going to tell them, they're going to ask you, because that's the reason they have actually, they are so concerned after the problems in the previous pregnancy. Thank you so much. And do we have the experts to say something about this, or should we move on to the next question? Sir and Dr. Rana.
The only thing I can tell you that high soluble fluid ratio in prior pregnancy is not really related to development of preeclampsia in subsequent pregnancy. We looked at that too. Okay. So it's kind of a placental thing for that particular pregnancy. There is some data, and it's not related to soluble fluid, but maybe some data with PLGF related to mid-pregnancy PLGF and long-term cardiovascular disease. There are other markers of cardiovascular health, such as we've been looking at activin. It's a marker of cardiovascular health, which is high in women with preeclampsia, and it's even high in like later on 6 months, 1 year postpartum. But in general, some of these tests that we typically use to predict short-term adverse outcomes during pregnancy haven't really panned out to predict who is the person who's going to have postpartum cardiovascular disease or postpartum hypertension. So that's still very much clinical. So we kind of wrote that in the hypertension guideline the last year is because they're not really good markers that can predict long-term cardiovascular disease. But here I agree with everything that was said about aspirin and calcium, yes.
But there is definitely an association with a high biomarker in the third trimester with postpartum hypertension.
The immediate postpartum hypertension, yes. So that's the paper that we wrote. And I think that's some of that, when the soluble fit really goes tremendously reduces immediately postpartum. So that could just be some residual hypertension from, nobody really knows why women will develop de novo postpartum hypertension. I mean, where is that coming from? Your placenta is already gone. So maybe there's some residual endothelial dysfunction. Some people believe that it's macrophages, but maybe some people believe it's the sensitivity of the patient's vasculature, although the pregnancy is already over. So there's a little bit of a confusing picture, but yes, so the biomarkers, if they're really high just before delivery, they do predict immediate postpartum hypertension. So maybe the first 3 days or so postpartum, but not really. If you talk about recurrence risk and you talk about, hypertension 1 year after pregnancy, that's like really hard to predict with some of these biomarkers that we have.
There's just one doubt I wanted to ask, whether these biomarkers, as Dr. Sharoshana was telling, that immediately before delivery, if they're elevated, probably they will have immediate postpartum complications. So can we repeat them after delivery, maybe by the end of first week, to see whether any of these patients are going to develop long-term complications or probably atypical features postpartum?
Not really. No, I think the soluble fit is like almost undetectable after the first couple of days postpartum. Yeah, no. So I would say, I mean, you can do a study and show what the levels are postpartum. There are some studies, I've never done it, but just every time we measure it postpartum, it's like not there. It's almost impossible to measure. It's below the detection limit. Yeah. So I would not. I think postpartum, we should just manage them by their blood pressure with their symptoms, giving them standardized management for postpartum blood pressure, keeping their diastolic blood pressure low, do home blood pressure monitoring, frequent follow-up. So like we always bring our patients back within 7 to 10 days postpartum, do a phone visit with them, educate them about signs and symptoms of preeclampsia postpartum. So yeah, I think we're still kind of in the clinical realm in the postpartum world.
Okay, thank you.
Unfortunately, what happens is most of the obstetricians think once the patient is delivered, everything is over. And we don't,
that's another thing we need to change.
Blood pressure is checked. That is what I've seen in the practice.
So crazy.
Not even the blood
just
pressure
for
is
everybody
checked
to
the
know.
next day.
Yeah.
I think we need to change
just for
our
everybody
system.
to know. Oh, absolutely. So CDC came out with these kind of maternal mortality in United States. 30% of deaths are occurring antepartum. 70% of maternal deaths are occurring postpartum. Out of those 70% maternal deaths occurring postpartum, half of them are occurring within the first week postpartum, and half of them are occurring within 1 week to 1 year. So if you can somehow manage your patient for the first week postpartum, you will really reduce a lot of morbidity. So a lot of work that I'm doing is just the first 30 days postpartum. Like, what can you do? Keep them engaged, give them blood pressure cuff, manage their blood pressures, give them Lasix, bring them back to your clinic, give them symptomatology, keep them engaged, because that will tremendously at a population level reduce your morbidity. So you're right. I mean, we're kind of so hung up on antepartum management and delivering the baby timely, and the mom, we kind of forget the mom after the mom gives birth. So we have to really, and that's why there's a whole section, by the way, in your iShip about postpartum management. Like we wrote a whole independent section about it. So very important.
But true, we are also including a complete workshop on postpartum management of preeclampsia so that people realize it. Unfortunately, a few years back, we were always taught, maybe most of us when we were students, which has got ingrained into the brain of most of us, is that once the patient delivers, preeclampsia no longer exists. That was what we have been taught when we were young. And I think quite a few of the seniors are still teaching the same thing to the youngsters. We need to change that.
So we are also privileged to have our ex-Foxy president and great mentor, Dr.
Pankaj Desai.
So would you want to invite him to add something?
Yeah, sure, please. Dr. Pankaj, could we have comments from you, please? Dr. Pankaj? Is there?
I don't think he's there, sir. We'll move on to the next
No,
question.
he told me you'd be there only for some time.
Okay, fine, sir. The next important question that I want to ask is preeclampsia definitely has a root cause, and looking at the root cause, I mean, if you can identify the root cause, maybe you could prolong the pregnancy because you're tackling the cause and prevent an abrupt progression of the disease, and definitely do the surveillance with the biomarkers. So, Dr. Harini, do you think root cause evaluation has some significance with particular relevance to the case that we discussed also?
Definitely, Dr. Revati. Like, as you say, like the causes for root causes for, as you say, like the preeclampsia is, even if you talk even 24 hours, I don't think we can. One is the genetic cause, the second one is immunological causes, and the third one is the other causes, basically like implantation, the problems with the pregnancies. So basically what we are looking is the initial part, like the genetic cause and the immunological, the factors, basically the placental ischemia, like that is the placental hypoxia causes, that releases the anti-angiogenic factors like soluble SMS, like SFLT, SFLT titer, like the type 1 thyrokinase 1, and it reduces basically it reduces the vascular endothelial, the growth factors and placental growth factors, like angiogenic factors will be reduced. So anti-angiogenic factors will increase. That's why it causes the vasoconstrictions and vasospasm of the vessels, and the patient develops the pressure, like, the blood pressure and the liver changes and the kidney changes because of the endothelial dysfunction. So that is the reason what I'm implicating is the SFLT titer and PLGF has got a major role in as a biomarker prediction for the preeclampsia. Then, as you say, the other factors are basically the defective placental implantation. That is because of the artificial, ART clinic. It could be because of the donor egg, the donor sperm, and the various causes for that because of the defective placental implantation. So that is the reason. This is what we are going to predict. The root cause for the root cause for the preeclampsia is the placental ischemia is the factor in this, and the defective placentation. So that is the reason we are taking it as the biophysical markers, like the predictors for preeclampsias. Basically the split and the PLGF ratio. Is it
sure,
enough,
Dr. Harini? I
No.
think my slides are not moving forward. Just a minute. Yes, I think you've told a very important point that, just a minute, let me just see. I think I'm stuck somewhere. Yes, it is so important to understand that there could be autoimmunity, which could actually probably result in an inflammation, which could probably cause endothelial dysfunction. And this is what the biomarker does. And of course, there is a study. I'm not able to move ahead. Let me just stop share and reshare this. Just a minute. Just give me a second. So can you see my slides? Can you see my slides?
Yeah, we can.
Okay. See, this is a very important article that I want to actually show you, because see, we are aware that preeclampsia leading to placental insufficiency. So we're so typically looking at several abortions before we actually look at APLA. This is a study which is done on a small population, but most of these patients who had preeclampsia with severe features, who ended up into placental insufficiency, had, they did not really fit into the clinical definition of the APLA criteria, but yes, they were positive for APLA. So what we have to tell is, maybe this kind of population who give you a history of preeclampsia with severe features have to be supported with low molecular weight heparin. In fact, I have a study which says, yes, give low molecular weight heparin, and this can probably reduce the incidence of preeclampsia. So it's not always about the serological markers and the clinical definitions of APLA, which could probably be fitted into all these kinds of patients. So this is a very enlightening study. So if you have somebody with preeclampsia with severe features, please strongly suspect APLA. And most of these patients also have an autoimmune background, just like my patient did. And yes, low molecular weight heparin can give you that extra mileage and maybe prevent complications, or at least, postpone the disease for some time. So should we move on to the next question? Because looking at root cause of preeclampsia would be a big discussion. I have just restricted myself to this particular case where I've looked at autoimmunity as well as APLA. And, this is something that we have to look at, even if the patient does not have several abortions and has had preeclampsia with severe features. Please look at APLA, and that may give you a clue to start low molecular weight heparin. Now, long-term cardiovascular implications of preeclampsia.
Dr. Revati, would we be able to end in the next 5 minutes, please?
Yes, sir.
Because we are running really late. So I think I request all the panelists also to cut down the answers so that we finish in the next 5 minutes.
Sure, sir. So, Dr. Lalitambika, could you please let us know about the long-term cardiovascular risks of preeclampsia? Hello, madam, are you there? Hello? Hello? Hello?
Yeah.
Madam, could you please summarize the long-term cardiovascular implications of preeclampsia?
Yeah.
Madam, please go
Yes,
ahead.
Dr. Revati. Next slide, please. Yeah. See, the long-term, already we have discussed the short-term complications of preeclampsia. In addition to the immediate complication, women who have suffered from preeclampsia are known to have long-term complications even during their lifetime. They have higher propensity of developing early cardiac and cardiovascular complications like hypertension, diabetes mellitus, which is having complications similar to a cardiovascular disease, then stroke, even death, venous thromboembolic diseases, vascular dementia, and chronic renal disease. Next slide, please. Not only the mother, but the baby is also at risk of having long-term complications in terms of cardiovascular morbidity if the baby was exposed to preeclampsia in utero. And so we have to follow up these mothers, not only in the immediate postpartum period to avoid complication. Previous slide, please. One slide is missing. Next slide. So already we have discussed the immediate, no, madam, previous slide. Yeah. Immediately after delivery, we have to follow up. Already we have discussed, but 6 to 12 weeks postpartum also, they have to be called back for an evaluation, especially the blood pressure should be checked. And the cutoff of blood pressure for young women is definitely less than that recommended by diagnosis of hypertension older people. So if the BP is more than 120/80, they should be considered as a risk of developing hypertension, and they should be given advices to reduce weight, modify diet, that is lifestyle modification should be advised. And they have to be called back 6 months after delivery and check the BP. BP should be definitely less than 120/80. If higher than that, they should be alerted to the fact that the BP is abnormal, and they should be encouraged to increase lifestyle measures to lower BP. Next slide, please. So they have to be followed up after 1 year also for a similar visit. Check the BP. Not only BP, they should be subjected to additional testing like lipid profile, HbA1c, and high sensitivity C-reactive protein, which is an indicator of endothelial hyperactivity, and also urine albumin creatinine ratio. Then they should have, whenever they are found to have abnormal BP or any abnormality, they should be advised to have a physician reference. And annual medical review is a must for at least 5 to 10 years, because that is the period during which many of them will develop abnormalities. And every visit, BP should be checked, proper history should be taken, and lipid profile also should be checked. And any abnormality likely to develop within 10 years. So minimum 10 years follow-up is essential after a delivery with preeclampsia.
Thank you so much, madam. I think madam has to attend an academic meeting. So before she leaves us, I'll ask you this question on, yes, before you leave. Novel strategies for clinical management,
Yes.
Dr. Lalitambika. Would you want to highlight on this?
Yes. Next slide, madam. Okay. I think one more slide. Yeah, CHIPS trial. So we have been treating hypertension with different cutoff values. Till recently, we were asked to treat hypertension as such only when the systolic BP was above 160 and diastolic BP above 105 to 110. That undue reduction in BP was considered as a cause for placental inadequate placental circulation and development of growth restriction. But after the CHIPS trial, where less tight versus tight control of blood pressure was tried, and one arm, there was less tight control where antihypertensives were started only when the BP was 160 or 105. In the more tight control arm, the diastolic BP was to be maintained between 81 to 85 millimeters of mercury. So antihypertensives were started when the diastolic BP was 85. And if the BP fell below 80, the antihypertensive dose was reduced or stopped to maintain BP between 81 to 85. If the BP was above 85, the drug level was titrated to maintain BP between 81 to 85. And what is the outcome of the CHIPS trial? Next. So less tight control was associated with significantly higher frequency of maternal hypertension and various complications attributable to hypertension. But there was no absolute increase in maternal mortality or perinatal mortality related to this control of BP, but maternal complication due to hypertension was reduced. Next. And the second important change in the management that we should do is after the CHAP trial, that is the chronic hypertension pregnancy. Here also, the BP in chronic hypertension patients with pregnancy, again, the antihypertensives were started only after BP reached 160 by 105. But after this trial, the result has come out, we know that when we treat with BP target of 140/90, there was better pregnancy outcome than a strategy of reserving treatment only for severe hypertension. And there was no increase in small for gestational age birth weight as we thought earlier. If you reduce the BP too much, there could be more of IUGR. That was the concept earlier. But now we know, even if we treat and maintain BP at 140/90, there's no increase in incidence of IUGR, but the maternal outcome is improved.
Yeah, thank you. I'm sorry to interrupt again, but I think we are running really late. Revati, if you could conclude the panel, it'll be nice.
Yeah.
We are really running late now.
Yeah. Only one more.
You could just give us the conclusion so that the
yes,
delegates can have a carry-home message.
Yes, sir.
Yeah. And the third concept is that a lot of studies have come forward with using low molecular weight heparin for women with a high risk for preeclampsia. And after the meta-analysis, two potential strategies are brought forward. One is if the woman has a priori low risk, you can treat them with 150 milligram aspirin from 12th week onwards. But if they are at high risk with early onset preeclampsia, SG or fetal demise in previous pregnancy, you can start low molecular weight heparin and low dose aspirin to start before 16 weeks of gestation, regardless of the presence of thrombophilia. So these are the three newer concepts that have been brought forward. Thank you very much for Dr. Revati and team for including me in this nice panel. I have learned a lot from this panel. Thank you all, Dr. Prakash and Dr. Revati.
Thank you, ma'am. Thank you for being there. I'm
sorry,
but we are running late. We have no choice.
Yes, sir.
If you could straight go to the conclusion, please.
Yes, sir.
Yeah.
Yes, sir.
Straight to the conclusion.
I'm just
saying
really
one-liners.
Yes, sir. I'm just saying some one-liners on the questions that were in stock. Preconception counsel and risk modulation. Yes, of course. There's a high role because you have this patient even before she is pregnant. So you can modify the factors.
Revati, I'm here. Revati, I'm here.
Revati. Yes, Dr. Rajini.
Yeah, just few words.
A little shorter, please, Dr. Rajini, because
please. Time. Yeah. See, so much of we have spoken about the biomarkers and other things. So this has to be sensitized to the patient. because that is the one thing where we had to modify. It will modify our management as well as the treatment, and even the follow-up of the patient also will be well known. So preconception counseling really is very, very important, where we need to emphasize the screening, where she has to get a first trimester screening, and as well as the biomarkers at 27 to 28 weeks, where they definitely, we have shown, studies have shown outcome is very bad when with the associated modified risk factors as well as biochemical markers. So preconceptional counseling is very, very important. So I emphasize a lot. All the practitioners should stress the need for them to follow, and they should have a role model where they should know these are the complications where they're going to face with all the stages of pregnancy, and we need to terminate the pregnancy, and the need for that baby care, NICU care facilities, blood facilities, tertiary care center, all that we need to emphasize in a preconception counseling. Regarding the risk modifications, where meta-analysis and systematic review, they have shown that several clinical link factors, either alone or in combination, might modify the women in early pregnancy who are at risk of preeclampsia. As we all know, the first thing what we have said, immunological causes, antiphospholipid syndrome is ranking the first with the 17.3. Next comes those with the prior preeclampsia, maybe the second, and a chronic hypertension, maybe the third. So the risk factors definitely we need to, risk stratification has to be needed for the management of patients with preeclampsia. And the studies which they have shown that the multiple theories behind preeclampsia etiology, as we all know, till now we are not sure of the etiology, but still we then briefly describe the predictive statistical models that have been created to improve screening detection rates, which use a combination of the biophysical, biochemical, as well as aspects of the patient medical history as inputs.
Ma'am,
so these all are needed for the risk classification. Thank you. Thank you.
Thank you all very much. I'm sorry to butt in, but then we have to end. Dr. Revati, can you straightaway go to any carry home messages?
Yes, sir. So the other thing that we wanted to emphasize is, yes, the first, preeclampsia is a disease which is diverse. So very, very important that we map. And it's never typical that the patient comes to you in the first trimester, given an opportunity, do the first trimester combined testing, and then do the surveillance and monitoring even after starting aspirin. And there the biomarkers can definitely be of help. This is what we were trying to tell you, the FIGO recommendations. And aspirin has clearly told you that, yes, by starting aspirin less than 16 weeks of gestation, you can prevent the incidence of preterm PE by more than 60%. But you do have to use other methods also to prevent, the onset of severe features. And yes, the Maxalf has been emphasized for critical management. You cannot forget. And yes, you can use techniques like the full Piers model if you're not using the biomarker after the patient is admitted. Maybe that can help you predict who is going to probably have a complication. And of course, the antihypertensives, please look at the HELLP newest guideline 2021, where you really understand how to use the antihypertensives. You cannot use multiple antihypertensives, use the single antihypertensive to the maximum, and make sure that you're able to control hypertension well. And the role of antenatal corticosteroids, just like how Dr. Rana has emphasized, you can choose your patients by doing the biomarkers. And yes, the novel strategies have already been highlighted. So preeclampsia is a complicated disease. Gone are those days where you want to treat a patient only when she throws a fit. So be very watchful, be preventive, be prophylactic, and make a difference to the outcomes of both the mother as well as the baby. Thank you so much.
Thank you. I think it was a wonderful panel. I'm sorry to have cut down a little bit, but then, this is a preeclampsia is a topic that you can discuss for hours together.
Thank you so much, sir. And thank you so much, Dr. Sarosh Rana, for giving those valuable insights.
Thank you.
Thank you so much. And I think we move on to the PenI segment. We also have some of the aspirants who want to give the this thing. So Dr. Anu, can you please take over from here?
Thank you all the panelists and the moderator for the wonderful discussion on preeclampsia, severe complicated preeclampsia. Now we would go on to the capsule, a short description on the making of preeclampsia education for the nation India. I invite Dr. Deepti to do the honors of letting us all know what went into the making of the PenI project.
Thank you, Dr. Anu. Saiti, can you just share the slides? So PenI is a certification course for the practicing OB-GYN people for teaching the models with the latest updates on the hypertensive disorders with special emphasis on pre-eclampsia. So it is a collaborative project of both SMFMI and HELLP. Next slide. And the PenI organizers, as we all know, is our Dr. Prakash Mehta. The secretary is Dr. Revati, and the global co-chair is Dr. Sarosh Rana. So why PenI? As we know, pre-eclampsia is one of the leading causes of maternal morbidity and mortality in India, especially, of course, after hemorrhage and infections. And there's no clarity on the proper guidelines, the classification system, the management protocols for the hypertensive disorders of pregnancy, with special emphasis on pre-eclampsia. And there are a lot of atypical presentations of pre-eclampsia, as we all know. And this causes a lot of clinical dilemma in delaying the diagnosis, contributing to maternal and perinatal outcomes. So because of this, there is implementation issues in the case of urban and rural settings also. And these different challenges have made us extrapolate the global research and guidelines into this population. And because of this, there's a special need for the source and to compile all the clinical research protocols relevant to Indian practice, which has to be addressed. Next slide. And our supports for this PenI program is the Roche India's Diagnostic Private Limited and the SMFMI office staff, which is Shrikant, Rajgopal, and Dr. Meghna Srinath. And the knowledge part, for the thing, we have this Medinet, which is the knowledge and the hosting partner, which will support us for the content, for the registration and the course propagation. So these are the SMFMI office people who are a big help to us. So Shrikant, Rajgopal, and Meghna Srinath, who are coordinating with the meetings and who are making the MOUs and other documents from the faculty. The office staff has also helped us in the content structuring, the brochure designing, and all the content plagiarism. So the creation of the PenI helpline to cater to the project from the delegates, and the collaborative efforts linking the delegates and the course faculty through the email is also being done. So designing of the modules, it is a collaborative effort with emphasis on translational research, designing the course to be clinical friendly, and the definitions, classifications, the management dilemmas, the evidence-based protocols for comprehensive learning and understanding. The structure and the content of the PenI. So basically the different modules. The first module will be with the introduction, which will tell us about the definition, the etiopathogenesis, the classification of the hypertensive disorders of pregnancy, the maternal and fetal surveillance in pre-eclampsia. The second module is about the pre-eclampsia, which is the latest clinical updates, the problems and challenges from the Indian perspective, the management strategy in the low resource setting, and the third module comes with the recent advances. Previous slide. Hello. So the recent, the third module is about the recent advances, which is the prediction and the prognostication of pre-eclampsia, role of biomarkers, the angiogenic biomarkers, and the PrEP model. And from the Indian perspective, the SLFT and the PIGF, the glycoxylated fibronectin. The fourth module is about the clinical challenges, that is the management protocols and dilemmas, which includes the strategy for averting the complications and preventions of pre-eclampsia. And the fifth module is the cutting edge concepts. The fifth module is the first trimester screening for pre-eclampsia, the role of aspirin in pre-eclampsia. Next slide. So basically the implementation, the salient points is PenI, which is the pre-eclampsia education of the nation, India is a novel project, which is a online collaborative certification course based on the latest evidence-based information on preeclampsia. So this is a collaboration of both the HELLP and SMFMI India. So there's no program which exists till date for this formal education. And this will help the clinicians from all over the country and beyond with the knowledge of management of preeclampsia, with all the current updates and evidence-based medicine. This was launched on May 22nd, 2021, which is the World Preeclampsia Day. And this has our current target audience is the full-time working professionals with a dedicated clinical practice. And we have faced many challenges during the propagation of the course. A number of candidates were interested in the course and prompted for more information. We contacted them personally via the phone, WhatsApp, and through email. And conversation from the inquiry to enrollment to course completion was our primary challenge. So the registered candidates will have a 6 weeks full-time course. So 6 weeks of full-time access to the course, and the candidates will watch all the pre-recorded lecture videos. And these lectures will be designed by all the renowned faculty in the country and in the world, and will have exceptional work in the field of preeclampsia. So, and these candidates have to finish the course with an exam. So they will have an online assessment, a 60 minutes assessment on the objective-based test, as well as a case-based comprehensive test. And they can also even download this booklet, which is the Pearls of Wisdom, for future reference. Next slide. So assessment and certification course has been very vigorous till now to assure the standards of the course. It is high, and the candidates who fail in both attempts are required to re-register for the course. And the main reason for the dropout most of the time is for the on-site for the virtual platform, and they're prompted to host an on-site one-day course for the certification. So there is, we have been collaborated with the OBG societies of Mysore, Salem, Hubli, Dharwad, and many other districts from across the country. Now we have even Bangladeshian students with us, and around 50 to 100 clinicians will be trained and certified at one time. And this is planned from September 2021, and this program is running parallel to the new chapter modulation of SMFMI. And the expected completion of the pilot is 6 months. So as we all know, we have been working on this, the PenI project implementation meetings and the virtual learning series on preeclampsia. So we are very proud to say that we already have our first batch of pass outs with the certificate. And they have come out with flying colors. And we had this Viva setup for the candidates. So those who scored between 70 to 74% were re-evaluated with Viva. And this was conducted by the Indian co-chairs through the Zoom platform. And the whatever education program, that is the Pearls of Wisdom, is a booklet which can be downloaded and can be used by them for their future reference. A feedback form was also being given to rate the certification course, to know if they were happy with the content of the scientific sessions, and it was very comprehensive, and we wanted to know even rate our faculty. So coming to the statistics, so 102 delegates have been there till now. And we had 9 delegates, as I told you, from Bangladesh. So from across the country, around 100 delegates and 9 delegates from Bangladesh. And there were 14 live interactive sessions done. And the certificates were issued to the past delegates, that were around 31 of them. So the future of the course would be, we would like to, go to the medical colleges and have a one-day course programs. And we would like to have more, these programs across the country. And as we know now, the Bangladesh people also have been included. And we would like to empower the clinicians with the latest evidence-based guidelines and research on preeclampsia, which helps in reducing the maternal and the perinatal morbidity and mortality. And we would like to, at the grassroots level, even train the nurses and the paramedical staff also, in order to emphasize on the diagnosis, the stabilization, and the referral protocols. We are trying to even reach out to the PHCs, the primary healthcare centers, and many MBBS doctors, and even the Ayush doctors to, basically to reduce the maternal morbidity and mortality. And we are also reaching out for global organization for extended support. And to support the pre-eclampsia, we would like to require support for the pre-eclampsia research in the future, which will enhance the quality of care in our country. So we should all join hands to save lives.
Thank you so much, Dr. Dipti, to walk us across the making of the PenI. Next, I would like to invite Dr. Shivajyoti P. She's a candidate of the PenI project who has successfully completed. I would like you to take a few minutes to talk about your experience with us, Dr. Shivajyoti.
Hi, ma'am. Good morning. Good afternoon to everyone. So I'm Dr. Shivajyoti, and I have taken the PenI course recently. And the information given in the course is very useful in the clinical practice. And yes, we are looking forward to put all the knowledge which we have gained in this course in our clinical practice. And yes, it is helpful in triaging the patients and getting a better monitoring for the preeclampsia patients. And yeah, the course is very useful, and thank you for all the delegates who has helped us to share their knowledge and putting forward their experience in this course. And yes, I'm really thankful for the PenI course for giving me this vast knowledge on pre-eclampsia. Thank you.
Thank you so much, Dr. Shivajyoti. Next, I would call upon Dr. Shweta Sakhe, who also has been a recent pass out from the PenI project. Hi, Dr. Shweta. Hi. Your few words about how your time at PenI was.
We request the delegate to introduce about yourself. Where are you from? This would add value to the audience. Shweta, can you tell where are you from and what is the background also?
Dr. Shweta, you're muted.
Right. Sorry, can you hear me now?
Yes, please introduce yourself.
Yeah, I'm Dr. Shweta. I've just recently finished this course. It's a great opportunity actually. And the main advantage of this course, which I understood, is as per our timing, we can attend the classes, which is the biggest advantage for us, especially when we have morning shift, afternoon shift, night shift. We don't know exactly when the class will be, when to attend and all. But the biggest advantage was that according to my comfort, according to my timing, I could open the classes and listen to it, which made me very useful to understand the concepts. And all the people who have, all the doctors who have presented the case discussions were very, very, very useful. Really, it was a great thing which we have done. And I would like to thank everyone who took this course idea and they're taking it forward very successfully. Thank you very much.
Where are you from, Shweta? Where are you from, Shweta? Which part of India?
Hello, ma'am. I'm from Bangalore, ma'am.
Okay. And which medical college or where are you working?
Currently, I'm working at Fortis, Bannerghatta Hospital, ma'am. Bangalore, Bannerghatta area.
And congratulations, because all these pass outs have scored more than 75%.
Thank you, ma'am.
So
thank you.
Done really well in their assessments. So you should be awaiting the virtual interactive session soon.
Sure, ma'am.
Dr. Anu, can you please ask Sahiti Priya to play the iShip introductory video?
Yes. Sahiti, are you online?
Yes, ma'am.
Yeah. Can we go to the ISHP introductory video, please?
Sure.
So after the video, if you'd like to give a few words about ISVG, you have given already with your introduction talk, but then inviting all our delegates to the same. Thank you, Sahiti. Sir?
Yeah, thank you all very much for joining this program. I think Dr. Sarosh has been staying with us almost till midnight. So thank you very much for being there. We always appreciate your support. You know, I have to thank Anu because she has taken on her head the arrangement of all this last 6 programs on her head. And she has been doing a wonderful work. Thank you very much, Anu, because most of us are busy with the HELLP conference and you have managed to look after this program very, very well. And I take this opportunity once again to welcome you all, not just to attend the HELLP World Congress, but to make sure that you present some papers so that India's name in the world of research should really go up, and it is with you all to hold our flag being held high. So see you there in HELLP Congress. Of course, before that, we will definitely be meeting in the more of the PenI programs that are going to come up in future. Thank you all very much for being there and enjoy the rest of the Sunday. Thank you.
Thank you.
Dr. Sarosh, you want to say something?
No, I'm good. I agree with everything. Yeah, keep it going. It's fantastic. Very good.
I am bestowed with the chance to give the vote of thanks, and I would want to make 2 sentences and say thank you all of you. Thank you especially Ma'am Sarosh Rana for staying up so late in the night with us and giving glimpses into the wisdom of pre-eclampsia and its treatment. Thank you so much, ma'am. Thank you, sir. Thank you, Dr. Revati. Thank you all our panelists, Dr. Lalitambika, Dr. Himapriya, Dr. Harini, and Dr. Rajni for having a wonderful panel. Dr. Deepthi for the capsule on PenI, and Dr. Sushma for the capsule on HELLP syndrome. More than that, like sir was saying, that I have put so much of effort into it, but that would have not worked so well without the help from Sahiti Priya, who is from SHIELD, who is our knowledge partner, and last but never the least, our office coordinators, Shrikant and Rajgopal, who is available all the time for any help that I need. Thank you so much, all of you, for helping us put together these VLS series. Hope to see you all soon for the next one, which is supposed to be held on Jan 22nd. Hope to see you all soon at that point of time. Thank you.
Thank you, everyone.
And we would also want to
Thank
thank
you.
SHIELD, Dr. Prachi and Mr. Zingade for supporting us on this platform. Thank you so much, SHIELD, for helping us launch these series. Thank you so much.